agenda, but let's go ahead and start with the official roll count so that we can get started. Thank you.
Laurel Williams.
Here.
Wayne Goodman, I believe, will not be here today. Dr. Liberzon.
Here.
Dr. Harper.
Here.
Dr. Wakefield.
Here.
Dr. Mitchell.
Here.
Dr. Thompson.
Here.
Dr. Martin.
Here.
Dr. Podewelz.
Here.
Dr. Farmer.
Here.
Dr. Nemiroff.
Here.
Dr. Strakowski. Dr. Ton. Dr. Robert. Dr. Wagner.
Here.
Dr. Vo. Dr. Suarez.
Here.
Dr. Babato.
Here.
Dr. Pliska. Dr. Pliska.
I am here.
Dr. Blader. I thought I saw Dr. Blader.
Yeah, I'm sorry. I had it
Okay.
on mute. Apologize.
All right. Dr. Chapa.
Here.
Mr. Patriarca.
Church. Here.
Dr. Bryant.
Here.
Ms. Nichols.
Here.
Dr. Tominga. Dr. Ibrahim. Sonia Gaines, I don't believe will be with us today. Scott Schlacklin. Elizabeth Meyer.
Here.
Dr. Wesley.
Here.
Dr. Keller.
I'm on for Dr. Keller. This is Shannon Gangerty, and he will be on in just a little bit.
Okay. Dr. Martinez.
Here.
Danette Castle.
Here.
Dr. Lakey.
I am here.
And Dr. Borges.
Here.
Okay.
So I think we're easily at quorum.
Yes.
Okay. Very good. Well, again, welcome everyone. I have been advised that we need to make sure, if we can, to turn on the cameras for the people that aren't, that are the members of the executive committee that aren't in this room to follow the Open Meetings Act. And also a quick reminder on the chat function that in order to be compliant with the Open Meetings Act, we have to be careful in what we put into the chat box. And if there are messages to us about something we need to do, we can handle that. If it's a general comment related to what we're doing in the proceedings, that needs to be voiced in the open meeting in order to be in compliance. So with that, why don't we go ahead and get started? And I'm going to go a little bit off script here, and I'm going to take a little bit of executive privilege, so to speak. I think all of us that have been in tune with what's going on in the world right now have been touched by what's going on in Ukraine. And again, I don't want to get on a soapbox. I don't want to be preachy, but just watching what's going on right now in the world. And, we are here to improve mental health services in Texas. Can you imagine what's going on in kids' lives right now in Ukraine as their parents are being conscripted, are on the battlefield, as they're losing their parents, as they, 400,000 refugees right now. Dr. Nemiroff, talk about trauma. Can you imagine what's going on right now? And we've been struck by, at least I have, by the bravery and the patriotism and the courage of people right now as they're fighting for their freedom and their country. And I've been touched by soldiers that were sent from one country to another that really don't know why they're there, that really aren't that old in the midst of this, and the impact that's going to be going on in Russia in the families of people, as it's going to, I think, have long lasting impact, and the devastation. And so I think it's fitting and proper when I'm around a group of mental health experts that are dedicated to trying to improve the lives of kids. If we just take just a short time of silence, you know, especially right now, because the peace talks are going on right now. And however is in your custom to take a little bit of silence, why don't we do that before we start, please? Okay. Well, again, thank you for allowing me to do that. Council for allowing me to do that, and for everyone else for your patience with me. So with that, why don't we go ahead and get started?
I just wanted to tell you something, David. I'm sorry. I want to thank you for doing that. I am well connected to this area of the world. I come from there. And anybody who cares about what's going on with humanity and human have a hard time to focus on other business while this is going on. So you're taking a moment and acknowledging that and talking about it in such a way really encourages me and others to continue doing our job. Thank you.
No, thank you, Israel. It's,
David, let me add that my father's side of the family comes from.
can you turn on your microphone? There you go.
Okay, yeah, my father's side of the family comes from Kiev.
Hmm.
There's a town of a few 100,000 called Nemirov in the Ukraine. And so I appreciate also you bring this up. It's obviously a terrible time.
It is a terrible time, and it's hard to at least for me to concentrate on everything else when I see civilians' lives being just uprooted and buildings bombed and everything else that's going on. So thank you. So with that, the focus now on our agenda, and two things that we need to do first before we get into the updates. We need to approve the minutes first from the November 15th meeting, also from the February 15th meeting that we had on the ARPA funds. We'll take those as two different items. And so if we could start with the November 15th, if everyone would just
Move
I
to
have a
approve
motion.
this Paula Wiltz.
Thank you.
Second, Isham Ibrahim.
Second from Dr. Graham. Any further discussion? Hearing none, all in favor signify by saying aye.
Aye. Aye.
Those opposed, nay. Anybody abstain? So those approved unanimously. Let's go now to the February 15th minutes. Please take a quick look at those.
Move approval.
I have a motion of approval from Dr. Wagner. Second from Dr. Nemiroff. Any further discussion? Hearing none, all in favor of passing those minutes signify by saying aye.
Aye.
Opposed, nay. Anybody abstain? All right, those have passed. So let's now jump into the business of today. We have a lot of updates, a lot of work that's taking place, and you know, a lot of work that you guys have done over the last since our last executive committee meeting, and look forward to hearing how things are going and the new programs and how we are learning from each other to make these things even more functional and more impactful. So with that, why don't we go, the first item that I have here is an update on our communications outreach and engagement from the University of Texas at Austin. Melanie Susswine, are you there?
I'm here. Can you all hear me?
We can, yes.
Okay, wonderful. Nagla's gonna run the slides for me. Thank you for having us. And it's very motivating and quite an honor to work on this project. So I'm happy to be here today to give you all an update. So next slide, Nagla, please. So today I'm just going to give an update on where we are with the communication plan and leave time for any Q&A that you may have. Next slide. Thank you. So just as a reminder for the Center for Health Communication, I presented this slide last time I spoke, and this is the process we use so that our tactics and strategies are evidence informed and research based. And that is our process. And I wanted you to have that if you review these slides later so that you see that. And this next slide, and this is another way for you just to have that. I presented our logic model last time, and we just like to ensure that everyone remembers and is able to see the inputs into our communication strategies. Thank you, Nagla. Next. So when I presented last time, everything here with the check mark is what we have done since we last spoke. In the fall and in the beginning of winter, we were very much onboarding and doing our research. And now we have presented to the right there is the communication and outreach plan, which we presented and we are starting to utilize. Next slide. And where we are right now, right now we're starting to move from the research into the implementation. And I'll show you some things that we have already progressed on. And this is what is next for us as we continue to move forward through the spring and summer and next fall and winter into the implementation. Next slide, please, Nagla. When we did our research, we spent time doing a fairly in-depth environmental scan, also conducting provider interviews, and did focus groups with each of the HRIs. And this is where everything is based. We spent a lot of time reviewing different websites nationally and came up with these strategies that I'll show you on this next slide. So before I move to the strategies, let me actually go through this slide. When we did the research, we come up with these message themes. So everything that we will be communicating is based on this left column, which are broad message themes. From those themes, we then move into targeted messages and refined messages. But we want, when we create something, to be able to circle back to these themes. And these are the themes that when we were talking with doctors or doing the other parts of our formative research, were either barriers that needed to be addressed or motivators. So you can see peer-to-peer collaboration is a motivator. Billing or coding opportunities was a barrier that we heard from and read from people, not understanding that they can appropriately code for the time that they spend, the providers. So we want to message around that and just provide a little bit of education. Another theme is time for providers and time for patients. These, as you all know, we just heard the busyness in providers' voices and want to address that and acknowledge how much providers are doing right now. Also, the educational opportunities were very motivating for people, the ECHO series and the CMEs. A discomfort in domain is a barrier that has an opportunity. So we want to address that CPAN is here for you, that we will provide the support. No call is too small. And that theme comes, a lot of those refined messages come back to the theme of discomfort in the domain. Also about the resources, how much time it's going to save providers, and it does save providers to get this vetted list of resources. That was a very big motivator in the providers that we spoke to. And then also just the increase in mental health concerns and issues that pediatricians are facing now because of the pandemic and everything else that's going on in the world. So those are the key themes that we will be anchoring the communications in. Next slide, Nagla, please. There are two main strategies that we're moving forward with. One is outreach and the other is media. And there are many tactics under both of those. Next slide, please, Nagla. So for outreach, we created an outreach plan that we will be presenting to the HRI CPAN leadership this week in a meeting. And we created this plan. The goal of this plan is to provide very specific outreach measures that the HRIs can do. We made it flexible enough. Someone asked me in the last meeting if our communication plan will be targeted for each specific HRI or if it would be overarching for the state. So what we tried to do in this outreach plan is to provide some overarching strategies for how to do outreach, but it's flexible enough for each of the HRIs. There is a self-assessment that they can take on a regular basis that has the key points of outreach in it. And we will also be participating in the CPAN coordinators meeting to offer outreach suggestions and to just be on the agenda with them. The other piece is the media planning piece. On the column to the left are the strategies and are the tactics, which we have already implemented: search engine optimization and Google AdWords. Social media, we will be providing to UTS and to Kosh the social media calendar now for a month that has several posts on it for Facebook, Instagram, and LinkedIn. So if you are on those platforms, we encourage you to share, to like, and it just will continue to raise the profile. Infrastructure outreach support, we are also providing right now. We are working on a video. We're starting some script recommendations. Our plan is to have a video that has an overview segment and then very short 30 to 45 second accompanying videos that track back to those message themes that will be able to be used in a variety of different ways. And then print and website updates too. And everything on the right is a column that we will be talking about moving forward as we move to the further implementation. Next slide, Q&A. So that is our update.
All right, very good. Do we have any questions? And again, I'd ask folks to use the hand function, the raise your hand function, or raise your hand physically here in this room if you have a question. Any questions? So Alex Vo, I see your hand, and then Dr. Trivedi.
Thank you, Melody, for a good presentation. I was just wondering on your provider interviews, do you think 12 is enough given the scope of the work for the CPAN across the state? And I was wondering also, was it representative of the various geography and regions, the various needs of the state, given there was only 12 providers that were interviewed?
Thank you. That is an excellent question. I tried to get providers from all different regions of the state, and industry standard when we're doing in-depth one-on-one interviews is generally 12 to 15, and the data became saturated. So we were hearing the themes over and over again, and it was one piece. So I felt comfortable, very comfortable in what we were hearing. It also mirrored what the internal and external evaluators I had seen in their reports about what the providers were saying. I would like to do additional informational interviews with providers who are not using CPAN and who are not as engaged in it. That is something that we would have liked to have done. But I feel very confident in the data that we got from those interviews as a piece to be able to move forward. It matched everything else that we had read and seen. Does that answer your question?
Yes, thank you.
Dr. Trivedi?
So, Melanie, thank you very much. That was fantastic. But so as a result, I have a question. You're focusing on CPAN, but as you know, with mental health, we want the community to be engaged, and therefore, as with research enterprise, similar things, are you planning eventually to try to engage the community in the research enterprise? Because unlike sort of esoteric research, what we are doing in both the networks is really in real clinical practice, immediately impacting practice. So to the extent we can bring in the community in this, the better. Any thoughts on how you would expand eventually?
I want to make sure I understand your question. Do you mean the community as in different medical associations? Do you mean parents? Do you mean the community groups that this HRIs are presenting to?
I'm thinking more tertiary, so that community of people, parents, community of real world populations, and not just academic medical centers.
Well, one of the partners that we're looking at, let me know if this answers your question, please. Some of the partners that we're looking at in order to do some of the digital advertising are like the FQHCs and the different clinics, because it was clear in the research how this is just in every facet of the community, and we want to be able to provide pointers to a go-to CPAN to the providers in the FQHCs. We explored the concept of including parents in the messaging. It's very interesting because the parents are not in the CPAN messaging right now. And if and we got very mixed feedback about that, more on the side not to, because of providers questioning where it came from. So we have that, but not yet. I really, really want to try the current strategy of where we're going to target messaging and see in responding with those themes. But we are aware and continue to think about if it is appropriate and when it is appropriate to bring in the parent.
Thank you.
Any other questions?
Just
Dr.
a
Martin,
comment. Oh.
Dr. Martin, I saw you take yourself off mute,
Oh,
so I was going to
I
hand it over.
didn't raise the hand. I didn't raise the hand, but yes, I just wanted to say from the point of view as the person here at Texas Tech, who's the one actually answering the CPAN calls and going around and visiting all the pediatricians and family medicine folks. And I felt like we were doing pretty well with our CPAN, but then I read over the initial draft of the plan that Melanie and her group have, and I really felt like it gave me some new direction. So I really encourage people to take a good look at it. And even if you guys are doing great already, I really felt like it gave us some new directions to go in that would get us even more people engaged with the same amount of time that we're spending on outreach.
Thank you,
Really good
Dr.
feedback.
Martin.
All right. Anything else?
I just want to echo what Dr. Martin said. This is Dr. Chapman as a newbie here to the group. I really appreciate all the information that you provided. It just gives me good info to use as I continue to move forward with our programs here. Thank you.
Thank you. And we're trying to be very accessible. So everybody should have my email. And I'm happy to answer specific questions if you have them, and to come to any meeting to present the communication plan in more detail, if that's helpful. After I present it this week to the HR leadership, I'm happy to do that.
All right, very good. Well, thanks, Melanie. Really appreciate you.
Thank you so
being here
much.
and the great work you're doing.
Thank you.
All right, we now have a series of presentations related to the work related to the American Rescue Plan Act. Maybe a little bit of an update before we jump into those items. The Higher Education Coordinating Board has officially applied to the governor's office for those funds. So we will hear back from them when the funds will be allocated to us in order to implement those projects. We have also sent, right after the last meeting, we sent a letter to the LBB related to the changing of the funding levels between the different projects. We haven't heard anything yet. They still have some more time to evaluate those recommendations. And we look forward to working with them to make sure that we are, again, very transparent about how these funds will be used. With that, why don't we jump into some of the specific new projects that come out of the ARPA funds. And with that, Dr. Wakefield, let me, I believe you're going to do the presentation on the Perinatal Psychiatric Access Network.
I believe I am.
Very good.
Great. Can everybody hear me?
Yes, we can.
All right. So we are going to talk just for a few minutes about this expansion, enhancement, and expansion of CPAN to what is now called PeriPAN, the Perinatal Psychiatry Access Network. Next slide. And we'll talk a little bit about, although I know probably most of the people on the call know very much about this, but for all of those listening and looking on, provide some overview and justification for the PeriPAN program, and then talk about some of the work that we've done so far and our plans and next steps. Next slide. So maternal mental health concerns are among the most common complications of pregnancy and childbirth, affecting more than 1 in 8 pregnant and postpartum women. At least 49,816 of the 377,397 Texas mothers who gave birth in 2019 had a mental health condition. Untreated, they are very costly and have multi-generational consequences, accounting for more than $2 billion in societal costs for all births in 2019 from conception through 5 years post-delivery. Nationally, half of perinatal women with a diagnosis of depression do not get the treatment they need. And thinking of all of those women that we were just thinking about and the moms in Ukraine and around the world who are experiencing distress in the US and also in Texas, that those consequences, those feelings of distress have consequences not only for their living children, but for children in utero. Next slide. Average cost per mother-child pair, $24,796 from conception to age 1. When we think about this is affecting 55% of this is coming from maternal outcomes and 45% from child outcomes. Really, this multi-generational impact when a mother is left untreated. And looking at children, $44,460 from conception to age 5. Next slide. This is a slide that is likely very familiar to many of us. This is a mental health professional shortage area map in Texas. Texas continues to have a high shortage of mental health professionals. And of all of the mental health professionals available, very, very few of them have professional training in perinatal mental illness. Next slide.
Well, actually, Sarah, quick question.
Yes.
What is that light blue county in the middle of the state there? Is
So
that
I believe that's Travis County.
really? Is that, or is that the county above it, like where Round Rock is? Who's good at their Texas geography? I'm just very curious. It's very striking.
Is that Luann? Weighing
Yes, this is Luann. It's Williamson County.
There you go. Very interesting. That's was until a few years ago was a relatively rural area, but it's grown tremendously. And I guess a lot of physicians have been attracted to that area. Great. Thank you.
I do remember a statistic that I don't have the reference for right here, but I remember a statistic that I heard many years ago that the DC area was the only area that had enough child psychiatrists on paper to see a child, per capita that were necessary, and they still had about a 4-month wait to see a child when necessary. So I think even when it's light blue, I'm not convinced that there are adequate mental health representation there, or mental health treatment, and especially not when it comes to children and to pregnant postpartum moms. So Texas has done some work on this, and in 2020, December of 2020, the Maternal Mortality and Morbidity Review Committee came out with some findings and some recommendations. Finding number 3, obesity, mental health, mental disorders, and substance use disorders each contributed to pregnancy-related death. And obesity contributed to about 35%. Mental disorders, other than substance use disorder, about 16% of pregnancy-related death, and substance use disorders with about 7% of pregnancy-related deaths. So the recommendation, the associated recommendation was to improve access to integrated behavioral health care from preconception through 1 year postpartum for women with mental and substance use disorders, saying that mental disorders, including those associated with substance use disorders, were a leading underlying cause of pregnancy-related death and occurred most frequently between 43 days to 1 year postpartum. So the recommendation was for integrated behavioral health care, where behavioral health and maternal and women's health care providers work together to provide high quality care to mitigate the risk for suicide and unintentional overdose. The goals being early identification, intervention, treatment, and appropriate referral for mental disorders and substance use disorders, because that can prevent pregnancy-related death. Recommendation to use social work, case management, and similar services to facilitate that connection with appropriate community resources. So we can see how the idea of CPAN overlaid on a perinatal population really meets many of these recommendations. Next slide. So there were many different resources developed. I'm not going to read this slide to you, but I do want you to know that one of our goals is to strategically use all of the different recommendations and the things that have been developed thus far in Texas and around the nation in looking at this perinatal population and improving frontline clinician education and comfort level, decreasing that discomfort in the domain that Melanie was talking about, and also increasing the linkage of women who are in need with available community resources. Next slide. So the purpose of PeriPan to support providers of mental health care with identifying and managing their patients' mental health and substance use concerns in real time, like we're doing with CPAN, in an environment in which reproductive psychiatry resources are scarce, which is really national, and to expand access to education about maternal mental health disease burden and effective treatments, to improve the mental health care and the systems of care for women who are pregnant and postpartum, suffering perinatal loss, or planning pregnancy in the context of psychiatric symptoms. And also, then we know doing all of these things will improve the mental health care and systems of care for children and adolescents of Texas by supporting the women who care for them. Next slide. I am honored and feel privileged to be named the medical director of this program, and we'll be working closely with the other experts that we have across our systems, and also with Dr. Williams at the COSH, trying to replicate and integrate CPAN and PeriPan. Just a little bit about my background. I specialize in child and adolescent and forensic psychiatry. I'm in fellowship trained in both of those areas and have been practicing in the perinatal area since 2014. I started a clinic and a residency rotation at that time, and have been active in national organizations and in developing perinatal educational resources for residents and obstetricians and pediatricians. Next slide. So we have identified in this pilot project, we're so fortunate to get some funding from the ARPA dollars to fund 4 sites for a pilot project across the state. The HRIs that applied and were identified and awarded some funds related to this is Texas Tech University Health Sciences Center in Lubbock, University of Texas Dell Medical School, Baylor College of Medicine, and University of Texas Southwestern. And I apologize for that typo there. But we've been meeting almost weekly for quite some time, developing some, working with the trait team, working with the COSH, looking at what we might be able to do to hit the ground running when these funds are available. We will begin to engage more and more people at these sites who will be the implementation experts and the consultant experts as well. I very much appreciate Jeff Newport's input and Laura Williams and everybody who has really participated on this, Nagla Lachelle, Luann, Dr. Lakey, everyone has been really phenomenal in thinking through how we can utilize the work that we've done on CPAN and all of the expertise that we have in our state to maximize our potential of this pilot project and hit the ground running when these funds are available. Next slide. So clinical consultants, we are engaging Gail Olson, who is the District 6 Chair-elect and the ACOG representative on the Texas Collaborative for Healthy Mothers and Babies. We are excited to work and integrate at that state level with our obstetric colleagues. Next slide. And we have a lot of stakeholders that have been identified. These are just a few. We actually have a very, very long list, but I wanted to show this list and to introduce the idea of the stakeholders. And if you had ideas, if you want to email them or state them here about, we really want to engage and not recreate wheels, but just make the wheel most appropriate for our perinatal population, our obstetricians and family medicine docs and midwives and psychiatrists and who are seeing women across the state who are or might be in the perinatal period soon. So these are some of our stakeholders: Texas Community Association of Community Health Centers, American College of Obstetrician and Gynecologists, the ACOG, March of Dimes, Texas Pediatric Society, Association of Texas Midwives, other state agencies looking at the ability to have direct services for some of these moms when necessary, and the Texas Collaborative for Healthy Mothers and Babies. Next slide. So metrics, we really looked at the CPAN metrics and tried to not recreate these wheels, because this is how TRAIT is already set up to collect these metrics, but make sure they are telling the story that we need to tell for PeriPan so that we can improve outreach and education and services over the long term. Percentage, the metric 1 is the percentage of PCPs and OBs within each pilot region that are enrolled. Percentage of phone calls answered by team and by entire pilot program within the 5 minutes. Percentage of consultative requests responded to within 30 minutes by team, by HRI, and by the entire pilot program. Percentage of enrolled clinicians using consultation services at least once by team and across the entire pilot program. Clinicians' PeriPan utilization satisfaction derived from satisfaction surveys developed by the internal evaluation team, and clinicians' comfort score derived from the satisfaction surveys developed by the internal evaluation team. Next slide. So this is a timeline. It's not going to stop in July, but this is how far we've gotten so far. We will add more to this. We are working hard on finalizing data and the phone specs and how Lantana is going to work and integrate between CPAN and PeriPan, and TRAIT is the same. Meet with other programs, both nationally and other states who are working on these initiatives. There are several states that have received additional funding recently through ARPA or through HRSA grants to try to integrate their child and perinatal programs, and some that are further along than we are. And so we want to learn from those programs. We will meet with HHSC and have a kickoff meeting with the pilot HRIs. So lots of work that has already been done and lots of work coming up in the next couple of months. So looking ahead, working on strategies to coordinate with other Texas State women's programs, meet with organizational stakeholders, and development of education and training materials. We are looking at really creating an educational menu, educating clinicians who are our frontline clinicians, helping and treating moms, educating our consultants who are taking those phone calls, and really developing a standard of care, working with other programs across the nation to develop that standard of care, and then also educating our moms and pushing out the education for access to resources and self-care. Next slide. Our plan right now is kickoff for summer of 2022 to have this line up and running. So we are actively working and excited and know there's a lot of work ahead of us, but we are honored for this opportunity. And that is the end of my presentation. Happy to answer questions.
Really nice presentation, Dr. Wakefield. Again, commit. I want to say I want to commend you on all the work that's taken place. Again, to everyone that's been part of this, all four institutions really have been meeting together, working together to try to get this in place as quickly as we can, doing all the preliminary work so that training is ready, that the policies are in place, et cetera, as soon as the funds are available. So really appreciate all the teamwork and all the work that's taken place. So let me go to some questions. Dr. Martinez.
Thank you, David. Thank you, Sarah, for that great presentation. I know you gave the overview with the statistics initially. Just wondering, I didn't see a breakdown, especially in Texas, as it references our communities of color, because there's a great impact, obviously, especially with Black women, but also with Latinas as well. And secondarily to that, when you looked at the metrics, I'm just wondering, how are you going to address, or are you planning to, because I would encourage it, having an equity metric there as well, so that we can see the impact that Peri-PAN will have over the course of time as we want to address any disparities or equities that may exist, especially when it comes to our communities of color.
Thank you, Dr. Martinez. Fantastic questions. Addressing the first one, you are absolutely correct. There is a wide health disparity. There was a recent article that Luann sent that you may have seen already, talking about in 2020, there was a 20% increase in postpartum mortality for women, and that overall affected much more women of color, both Latinas and Black women. And so that is something that is true in Texas as well. The second part of your question is that we have actually discussed that the difference between the ability to look at those items over time so that we can appropriately address them, or utilizing it as a metric. And so we have several things that are data points that we would like to collect, and that we will be collecting and are built into traits so that we can respond to them, but aren't necessarily metrics about how efficient the phone calls are being answered and how widely providers have been engaged.
Thank you, Sarah. Appreciate that.
Okay. Dr. Babato.
Thank you so much. I just want to, say a comment. Thank you so much, Dr. Wakefield, for that wonderful presentation. This is a much highly anticipated and needed resource, and I'm glad that we're paying attention to this. Regarding the statistics for the substance use disorder, just as out of curiosity, was there any particular substance use related to the 7% pregnancy-related death rates? And apart from that, are we going to be having any specific training for the providers to be able to answer consultation questions?
Thank you, Dr. Babato. Yes, the opioid overdose is the highest in that 7%. And then we are developing education and looking at what specific training would be necessary. Talking with Nancy Byatt, Dr. Byatt from the MCPAT for Moms program, and thinking about some leveling information, and also, of what those standards should be across Texas and across the country.
Dr. Wakefield, we've had some conversation about the different groups that we need to provide educational material to. I think one of those groups will be our colleagues that sit around this table, the people that work at your institutions, so that we have more individuals that are competent in providing perinatal mental health services, especially as we think, next session of how do we take a pilot to a statewide initiative. There's going to be a need for some of our institutions to make sure that they feel very comfortable doing that, and that'll be part of that educational mission. I think we've had discussion related to the primary care providers that will need to have our outreach so that they feel more confident in this. One of the groups that we will be serving will be mental health specialists that work in local mental health authorities and other areas that don't do a lot of perinatal mental health work, and so they may feel very comfortable caring for women when they're not pregnant, but once they get pregnant, feel like they need a little bit more support. And so that'll be part of that outreach. Dr. Wakefield, any other groups that you've thought through related to audience for some of the educational material?
Yes, Dr. Leakey, I think we've also talked about residents and trainees and thinking about what kinds of standards and residency training would be helpful for better preparing our residents for the more than 50% of the population they are likely to see as patients will at some time have either be pregnant or postpartum, or because we know so many women are seeking care. So thinking about, and there are some standards that have been developed with the National Curriculum in Reproductive Psychiatry directed at residents. So trying to figure out what is the easiest way to implement this in all of the different target areas. And then additionally, for moms themselves.
Very good. Any other questions for Dr. Wakefield? Seeing none, thank you again, Sarah, for all the work that you're doing, and to the rest of the team, to all the other HRIs that are part of this pilot. Thanks, Jeff. You've been very involved and really providing great support, and as have been the other HRIs, so thank you. So as we move to the next item, I want to recognize that we have a couple of executive committee members that have joined us since we did the initial roll call at the very beginning. Dr. Tominga, I see you, and so thank you for joining us. And Andy Keller. Carol, were you going to say something? Okay. And then Andy Keller. Anybody else that's the part of the executive committee that has joined since we did the initial roll call? All right. Seeing none, why don't we go ahead and move to the next item. Actually, is by Andy Keller, related to the collaborative care by the initiative through ARPA funds that's being led by the Meadows Mental Health Policy Institute. Andy?
Yeah, so I just want to acknowledge that I drew the short straw to go after Dr. Wakefield. So I'm going to look really bad by comparison in terms of a lack of presentation and a lack. So we're going to like bookend the possible range of things you can do for your presentation. So Dr. Wakefield's is the ideal. Mine is going to be the LITE version. So basically, we're overseeing one of the collaborative care projects. There's another sort of more in-depth one that has some specialized resources that the Dell Medical School is doing. With Dr. Coley, but we're going to talk about the one that we're doing that is basically pulling in, I believe, 9 of the HRIs as partners to expand the implementation of our Lone Star Depression Challenge, which is a 5-year project to help health systems across Texas implement evidence-based, primary care-based treatment for depression, which also happens, by the way, to work for all the other mental illnesses for mild to moderate cases. So, basically, I'm not going to give a presentation on that. We've talked about that before. I am going to just kind of tell you where we are in that process. So we had an initial meeting last month with the HRIs to just sort of orient them to it. That was before the awards were done, before we had the contracts in place. Now that the decisions have been made and contracts are being put in place, we are going to be having individual meetings with each of the HRIs to talk about what this means. And so the main thing I want folks to take away from this is that this is very individualized. It's going to look very different in a place like North Texas with UT Southwestern, who we've been working with for 3 years on this project. And we have 2 other grants that we're working with on them. We're going to have to figure out how to fit this in. And there's other grants like with Children's Health that are happening in a separate lane. So like that's going to be a totally different discussion than it is in the Valley with UTRGV, where we're going to have to talk about which of the things they're doing fit. And we've got time to do that. And one thing I think folks need to keep in mind is, we've got through the end of the biennium to get this done, but we also have additional grant funds that can help move things further along if things get slowed down or whatnot. So I think the main thing I want to kind of have folks take away from this is that this is a very individualized process. Your individualized questions, concerns, needs will be addressed. The only thing that's not individualized are the budgets. The budgets are defined. You have a set amount of money, and we've been trying to help people figure out, what the budget is for how they're going to spend that. But and the budgets include 2 items for the HRIs. One will be funding for your team that's going to help with the implementation in the health systems, the pediatric health systems that are targeted. The other is going to be grants up to $125,000 that go to the health systems to help them with their implementation. Everything from hiring staff to maybe gain additional consultation and handholding that they might need to IT changes. We are going to be the coordinating entity for the different grants, so that we'll also be talking with your folks about how that works, because we all know that the ARPA rules are very careful. So it'll be reimbursement based, your expenses, and we'll help organize that, make sure that there's consistency around that as you get reimbursed on that. Same for our reimbursement. And then I guess the last thing I would say is just how excited we are. This is going to be the largest implementation of evidence-based pediatric primary care interventions that we're aware of in the country. The scope of this is going to reach potentially, certainly hundreds of thousands of children, but potentially over 1 million Texas children. And I think in addition to just being a wonderful thing based on the evidence, it's also going to be a wonderful spur to our depression and PTSD research networks, because I would think there would be a lot we would learn, because while we know that collaborative care and measurement-based care are useful, we don't know all the things that we need to do to make them optimal at all. And so there'll be a lot of things that we'll be able to learn about different staffing models, different combinations with other treatments, special needs. One thing we do know from collaborative care is it does have very equitable outcomes. It's one of the few large scale things that have been looked at across Black communities, Hispanic communities, other people of color, older adults, other marginalized communities, LGBTQ communities. So there's a lot of great research that promises this, but there's also a lot to learn. And I think it'll be exciting to see what we all learn together through the research networks after this is implemented, which of course they're separate things and they'll have to, go through all the hoops they have to go through on that. But I think just the synergy of having something like this in our state is a pretty amazing thing. So happy to answer questions. I would just sort of say to each of the HRIs, if you are one of the HRIs, happy to answer your questions in front of everybody else, but we're going to have in-depth times with Melissa and the team. Melissa Rowan, by the way, is our lead on that. She's here too if she has any questions, if you have questions. So that's it.
All right, very good. Thank you, Andy. Dr. Pliska, I see your hand.
Yeah, I guess mine's a simple. So I said, take it, Andy. We'll just wait at the individual HRI level till someone from your team reaches out to us, and then they'll kick the process off. You don't need us to do any prep work at the present time. I just wanted to kind of confirm that.
That's right on, Steve. In fact, the first phase of the project is to do that prep work together. I mean, one big thing is to really sit down together, look at data. I mean, I think everybody has an idea about which health systems they want to plug into. We'll want to just kind of talk through that, make sure. And then, the engagement process is going to be really different. Some of you already have those health systems up and ready to go. Some of you don't. Some of you, really are going to need to do a lot of outreach. So we will come up with an individualized process, and we are responsible for setting those initial meetings up. We would like you to respond to us in a timely way, but we're sure you will.
Very good.
I will respond timely.
All right. Very good. Thank you, Andy. Thanks for your leadership on this initiative. I look forward to hearing about the progress. With that, why don't we go to the Substance Use Disorder Services Initiative, and Joe Blader has been leading this, the coordination of this initiative. And Joe, let me hand it off to you.
Thank you very much, David. I do have a few slides, and since, as it turns out, I'm slide disabled, perhaps I'll change my mind and ask Nagla if she wouldn't mind.
Nagla is pulling them up right now. Thanks.
All right, terrific. So what I'd like to do today is orient you to a program that I hope we'll be talking a good deal more about in future, which is the expansion of our adolescent substance abuse treatment, screening and treatment and capacity through the consortium. We're very fortunate in Texas to have several sites with immense expertise in this and related areas. So here at San Antonio, we have one of the leads for the opiate use disorder initiative throughout Texas, as well as the overall Be Well initiative, which is not just opioids, but also people struggling with alcohol use and use problems, dependency, as well as other substances. UT Health Science Center at Houston also has a fantastic team of specialists in their department who are going to be contributing. I'm very grateful for that. And same at Texas Tech at Lubbock, where their program in this area, while fairly adult focused, is going to be a huge leg up as we try to get this underway. And we're also lucky to be in partnership with UT Health Science Center at Tyler and our friends at Dell Medical School in Austin. Next, please. So the scope of the problem is reflected in this slide here. And these are data from the NSDUH, the national, it's an annual survey that's conducted, I think might even be on behalf of the CDC, but SAMHSA plays a very big role in it. The National Substance Use Disorder National Survey of Drug Use and Health survey that's conducted annually, and in their stratification of the current prevalence of substance use disorders by age, you could see that among 12 to 17-year-olds, and that's the bar in the middle within each grouping, 6.3% of our 12 to 17-year-olds are diagnosed with a substance use disorder or alcohol or illicit drug use. I'm sorry, it's 6.3 for substance, 2.8% for alcohol, and 4.9% for illicit drug use. So by, just to put it in perspective, we know that ADHD, for instance, is a highly prevalent and impairing condition in and the prevalence of youngsters who have substance use disorder is just about the same as ADHD, well over 6%. On top of that, the next, please. Next slide. The relationship is very strong between between substance use disorders and mental health conditions. In NSDUH, they focus on depression, but even just within depression, you could see that if you have you've had a major depressive episode in the last year, the likelihood that a 12 to 17-year-old also has problems with illicit drug use, marijuana, opioids, alcohol, and so forth is double to triple. And put another way, among 12 to 17-year-olds, given in this Venn diagram, if you look at the overlap between the yellow and the blue, that 644,000 represents about 40% of all those with major depression who also have a substance use disorder. And flip the other way, among the 3.5 million 12 to 17-year-olds with major depression, approximately 20% of them also have significant substance use problems. Nevertheless, the small fraction of people who receive substance abuse treatment who need it, it's really not a whole lot better for 12 to 17-year-olds as it is for the rest of the population. We know it's incredibly low. So only in the case of 12 to 17-year-olds, only 7.6% of individuals actually receive treatment. So our goals in this pilot we're endeavoring to get underway is to first of all implement systematic screening and matching intervention, matching need to the level of intervention that seems indicated, and this is basically territory that's been well developed through the SBIRT model: screening, brief, intervention, and treatment. Our initial focus is going to be on TCHAT to implement a systematic means of screening for the folks that we see. Of course, we do this in the course of regular psychiatric care, but the idea is to do this in a consistent way and in a way that furnishes data that helps to provide the level of support and treatment that's indicated based on the context and the problem. Then SBIRT, so you have your screening, you have your brief intervention piece, which is ordinarily something that we try to implement in the non-substance specialist context. So this is the kind of thing that we like to see primary care clinicians as well as psychiatrists be able to do for those who don't have a overly concerning substance use issues. So that's the next step up, and we want to broaden the skill set in that area, both in primary care as well as within our own psychiatric services. Then for those who need it, we are developing capacity in the specialty treatment modules that have been shown to be effective for adolescent substance use. And the linchpin of those interventions is basically a lot of family involvement, family treatment, very often anchored in a contingency management, multi-systemic therapy type of framework. In addition, cognitive behavioral therapy that addresses both issues around substance use as well as the numerous other, so to speak, underlying psychiatric conditions that have played a role in the onset of substance use, as well as pharmacotherapy as appropriate. We also want to create capacity for relapse prevention and monitoring for folks who are doing well and discontinue from the acute phase of treatment, because we know that relapse is a major risk, and being able to intervene in a timely fashion and provide that level of support can really have a very profound effect on overall outcome in the long term. And thirdly, we have the objective of improving outreach and education and training to a large extent in primary care. Annual screening for substance use problems and tobacco use, for that matter, are parameters that the American Academy of Pediatrics has said are appropriate for primary care, and we certainly want to be able to help folks do that effectively. Of course, one of the barriers to doing that is often, or lots of screening things, as it turns out, is that I will say, well, what's the point screening when there's not a whole lot I can do? There are no resources to send people to, or they're very limited, or a lot of them, they're not available to people with more limited means. And so our goal is to improve the quality and consistency of screening that's available in healthcare settings in the community, as well as be able to provide the full array, that full spectrum of services within the SBIRT model. Next slide, please. So this is a look at roughly how we're thinking about referral pathways. So the low-hanging fruit, of course, is TCHAT and that whole network largely through schools, because TCHAT is the main direct service component of the consortium's activities, and it's a very logical place to start. we hope in short order to be broaden the referral base to other health providers in the community, as well as finally fashioning some way for families or youth to self-refer. Target patient group for the specialty aspects of the service would, use 13 to 18, use of alcohol or substances screen based on the SBIRT model or screen right into the treatment range as opposed to brief intervention, or a pattern of very high risk use. So it may fall short of the diagnostic criteria for, chronicity and so on. But nonetheless, there are certain substances and in relation to also the settings where people are using makes a difference. Are they impaired when they're going to school? All those sorts of things would also play a role in the determination of whether what we have on offer for the specialty care part of the program would be warranted. Next, please. This is just an overview of some of the specialty competencies that we aim to develop and deploy and get some preliminary indications on acceptability, feasibility, and hopefully clinical impact. So various cognitive behavioral techniques, including motivational interviewing, refusal skills, alternate leisure activities, and so forth. With adolescents in particular, family-based models are known to be essential, and they're just listed some of the things that that a clinician specializing in this area should have some facility with. And finally, things that we're either considering and might vary between the sites based on our indigenous resources and other factors. So of course, pharmacotherapy, urinalysis, and PEth testing in the case of alcohol are very commonly used. We'll be thinking about what the indications would be for incorporating that in a particular treatment plan. There's some literature that in some contexts peer support and peer guidance could be helpful. We do want to tread lightly or very carefully with that area because some of the evidence for some groups is not as encouraging. But we're trying to have an open mind about what might be most effective in a given situation, and potentially for adolescents who might be so involved with opiates that they do need substitution treatment. We're thinking about whether we could provide medically assisted therapy in this context. Next, please. It's also important that we recognize our linkages to other programs and organizations. We'll be working on that in the coming weeks. And that includes, of course, HHSC, the Association of Substance Abuse Providers in Texas, Be Well Texas, and at our respective local sites, potentially juvenile court, family court. And this is our very tentative timeline, but we did want to sketch out roughly what our spectrum of activities are that we'll be trying to get a beat on, so that hopefully by month 4 or 5, we're down with really implementing the full spectrum of service. And that's all I had prepared. I want to, before I forget again, thank everyone who's collaborating with us on this. Special shout out to Dr. Lakey and Luann Southern, who've been very supportive and very helpful to our group in getting this underway. And I'm happy to address any questions.
Very good, Joe. Very kind of you. And thanks for all the work to put this together. So we have a little bit of time. Danette, I see your hand.
Oh, thank you. That was quick. All right. So Dr. Blader, thank you. That was a great presentation. And, I will just say, for someone who has been working for a really long time in Texas on the mental health front, and also recognizing for a number of years our inability to actually, or our failure, let's just put it that way, to really reach people well in regard to addressing substance addiction services too, that I really appreciate this work. I'd like to join you in conversation and connect you with some of our folks, because you may well be aware that over many years, the mental health system and the substance addiction system were actually kept very separate. And really still today, there are remnants of that in our system. We've been working really hard over the last several years using the acronym, I'll say it, TCMHCC, but which is an acronym which goes for Community Behavioral Health Community Clinic. So this is a certified approach that we're using. We are closing in on having all of the community mental health centers, local mental health authorities in the state certified. That should happen by the end of this month. We've also been working to get financing strategies lined up so that we can actually support the ability to provide a full range of comprehensive services for people in the community, which include substance addiction services. So that's one of the required elements of this particular model of care that really is probably the one that caused us to pull that model of care into the state of Texas. So we are getting to a place where we can actually not have to divide people in terms of where they go to get care, and try to decide whether or not their primary is in substance addiction services and the secondary in mental health, or the other way around. So that's one point I'd like to follow up with you, because we have a much higher level of engagement on the substance addiction front, and we'll have much to bring to the table in terms of providing services for people who have serious mental illness and co-occurring substance addictions, as well as serving people who have, as we might say, as though any of us exist in a single compartment, a single substance addiction issue. So there's that piece. The second, I have a question. I am interested to know if we have data in regard to TCHAT, the percentage of kids that are referred to TCHAT from schools, and the proportion of those that have both mental health and substance addiction needs. And that's one piece. And then of those kids, for those who are referred out for longer term treatment, what is the proportion of kids that have both? Again, I'd just be very interested in that. If we don't have it readily available, that's okay, but it's something that I would love to see and have a conversation about, because it helps us as we improve our ability to respond to referrals coming into our system.
Well, that's wonderful. Thank you so much, Danette, for the encouragement, the encouraging words, and the reach out so that we can collaborate and leverage your tremendous experience and your network, and through the organization and the LMHAs at our respective sites. Means a lot, and we'll be in touch, and consider yourself appointed to the steering committee that we'll be organizing shortly. With respect to, I could only answer impressionistically, and when I've asked about it at our site, I want to say that it's in the, depending on how you define it, some degree of substance uses or alcohol use that's kind of borderline, at least borderline worrisome, is somewhere in the 10 to 20% range. But we have to. That's just a very provisional guesstimate, pending our looking at the data statewide. As a practical matter, from the psychiatric context in our field, it's not all that common for kids to come into psychiatric care with a primary chief complaint or reason for referral of a substance use disorder. More like the more common scenario is that someone comes in for traditional psychiatric reason for referral or chief complaint, and then of course substance use turns out to be a very high comorbidity. We are nonetheless very well aware of the number of youngsters who, at least primarily, or where their biggest source of impairment, at least at the moment, is probably their substance involvement, because these things, almost by definition, like any addiction, they become habitual, take on a life of their own, and to a degree then somewhat refractory to attempts to treat the underlying psychiatric disorder that might have facilitated the onset of substance use problems. Sometimes it does take on a bit of a life of its own in terms of peer network and other factors. So we look forward to continuing the conversation with you, Danette.
So again, thank you, Danette, for your comments. Let us dive into the data and maybe give you a whole holistic kind of a view of what we can figure out from the training data related to the cross section there of substance use in the TCHAT program. I don't think I can give you all that data right now, but let's see if we can get that to you. I think that's a great question.
Yeah, it's important.
Thanks.
Mm-hmm.
And would love, Danette, for you to be part of this conversation. So thanks. Thanks for the offer. Yeah, very good.
Dr. Wakefield?
Yep.
Oh, thanks. My question is actually for Danette about the CCBHC model. I've been talking here locally with Star Care about that quite intensely, about some things that we can do. But I was under the impression it was really focused on adults. But it sounds like maybe there's some room to incorporate adolescents there as well. And could you talk a little bit more about that?
Yeah, so the certification itself is for both adults and children. It does not differentiate between the two. So there's an expectation for each one of the sites. Now, again, I'm going to say that if you want to think about a circumstance in which you get the horse before the cart and you do so deliberately, that is something that we have done as we have been working on the financing transition from the 1115 district program, which had really broad ability to, and a lot of latitude in terms of the use of funds, to a financing strategy that would be accepted by CMS. And, there's a lot of that has been caught up in the courts. It's been caught up at CMS, and many conversations taking place between our Health and Human Services Commission and CMS trying to negotiate to agreement. Coming out of that, however, is good news for the behavioral health system in that we have been able to secure, at least to this point, approval for a directed payment program for behavioral health services, which covers Medicaid population, and a charity care pool for behavioral health services for public health entities, also local health departments, as well as local mental health authorities to cover that uninsured population. As we began our kind of trek around in the 1115, many of the components of the CCBHC model, which had yet to be federally recognized, were in it. Substance addiction services being one of those. Peer support services, a major component as well. Care coordination, a particularly critical piece of it too. And so as we began to work on the transition, the federal government recognized the CCBHC model by legislation that was passed in 2014. Our agency started on a quest, the Health and Human Services Commission, along with us, in partnership with us, to bring that model to Texas. And so back to your specific question, it does cover children as well. That doesn't mean the capacity is there yet. I talked about the kind of the horse before the cart, because we are in a circumstance in which we're trying to get a model on the ground that actually is something that we can reach for and know that it will better serve Texans who have serious mental illness, both adults and children, but also trying to think about how we're going to finance that in Texas, because we do have a high percentage of people in our system who are uninsured. We have a Medicaid program that is not adequate. It doesn't pay for the level of services that are necessary to provide treatment for people with comprehensive needs. So, but that's what we're working on, and we're getting there. So we're getting to a place in which in many areas of the state, both for adults and children, substance addiction services is being brought in directly to be provided. In almost every area of the state, there's been coordination taking place with private providers as well as the local mental health authority, but there's not been the direct provision of service that is part of the required model. So we're not everywhere we want to be yet. I mean, we're not as far down that road as we want to get to, but we are on the road. So this is something that is really critical, as has been, pointed out by Dr. Blader. It's really difficult to treat when you can't get to the underlying issues. And whether it's a substance addiction emerges first, before there's ever recognition of mental health, or this story that we hear often, particularly around kids, young adults, is that when they first hit our system, crisis services perhaps tangled up with the criminal justice system, unfortunately too often, it's often difficult for a time to even sort what's going on. How much of it is driven by drug use and how much of it is driven by an underlying mental health condition, both of those things probably happening, and better treatment needed. And then today we have workforce challenges, like everybody, I think across the nation, but we're in a major situation. I think Williamson County would probably say they have shortages too. Probably wouldn't even want to believe that they're showing up on a map in which you can see workforce shortages across the entire state. But that's hitting us really hard. And we are having circumstances in which even kids and adults in crisis, it's hard to have the staff time to bear on the treatment side of it in a way that we need to. But, we're hoping that contraction of the labor market will ease, and with better improved financing, that we can have an opportunity to compete in the marketplace for practitioners. So all these things are being worked on.
All right, very good. Well, thank you, Joe. Thanks for the great work that you're doing. Thank you, Danette, for all your great comments today. And why don't we move to the next item, again, under the category of ARPA fund initiatives. And Dr. Trivedi, you want to talk about the Youth Aware and Mental Health initiative that you're helping to stand up?
Thank you very much. Can you hear me?
We can, yes.
Wonderful. Thank you all. So this is this is related to the TChat infrastructure, but slightly different. A lot of what we've been doing through TCMHCC is almost like crisis intervention after somebody's identified. This is a 5-session prevention mental health awareness program that is internationally evidence-based with randomized controlled trial evidence called Youth Aware of Mental Health. That has a multi-component piece, the major core, first core being that it requires trained facilitators. So we, in the last 5 years, have been doing through our Texas Resilience and Training Academy, trained facilitators that have been doing this in our local schools in North Texas, and we've reached about 20,000 students. Since we have been talking about it as part of ARPA, we have been having individual meetings and group meetings with all the HRIs that are participating, identified leads at each of them. We've created a steering committee, interacted with, actually, thankfully, with Danette and Sonia, because there are several things we do in schools. This one, unlike a lot of programs, doesn't depend on didactics. It is more inductive. So it's a 5-session interactive program that the facilitators that come here, it requires involved training. So it is a 5-day training session that is done by our team trained facilitators who will train people at each of the HRIs will go there. And the plan is to adopt the schools And each school then allows you to do this in the entire classroom. This is the major difference. Most of the internalizing disorders like anxiety, depression, some of the substance use, they don't actually manifest in a classroom easily. And therefore, most of the people with kids with depression and anxiety actually remain undiagnosed and sit in the back of the classroom, don't even disturb the class, but they are the ones who are the most forgotten. So this program is really designed to address the whole classroom, identify those kids who really have depression, anxiety, connect them to their counselors, and take them on the journey to improvement. So that is the goal. It will require all of the HRIs, and they are waiting for the funding to arrive so that they will then hire the staff. And we have already teams built, ready to do these training courses. Each training program is 20 people come here. They basically mimic a classroom, and they all go through the 5-day session trained, and then they go back to the schools. And we monitor their progress, and the metrics will be at the school level, at the classroom level, and at the student level before and after the program in all of these schools. We have worked with a lot of leadership, at least with Danette and Sonia's help. Thank you for that, with the mental health first aid program. Majority of that currently is in adults, but there is a youth version of it, which is both of those, and the teen version are all gatekeeper training programs, but there is the teen mental health first aid that is beginning to pick up in schools. So we are interacting with that group so that we are not basically creating confusion for schools. But I think that we've been able to figure that out. So the program will be officially launched as soon as places hire their first staff. We have the training programs and the classes already scheduled starting in May, and hopefully we'll have all the staff in many places. We have already actually, as a pilot / from other kind of programs, done this kind of training program. So there are several facilitators from Dr. Wakefield's department who were trained last year, and they are beginning to implement in their classrooms. So we already have a model in place to do this in Lubbock and hopefully across the state. The advantage is this is really going to address that initial gap, which we as a mental health field have done horribly in our field. Depression especially, we always wait for crisis before we intervene, especially in teens. And therefore, unfortunately, for the last 15 years, depression and suicide in the United States, and I unfortunately always pause at the point, has consistently gone up, while the rest of the westernized world, it has stayed stable. So this is really timely, and I appreciate all the excitement. I've talked to individual leads at all the HRIs, and they are very excited. So I'm looking forward to the time we can launch it.
Very good. Thank you, Dr. Trivedi. Any questions for Madhukar? Dr. Martinez.
Yeah, thanks, Madhukar, for a great presentation on YAM. I know it's international, and you bringing it here to Texas is fantastic. Just curious, when it's being implemented, is it done school-wide or is it done by classroom? I'm just kind of curious because I know it's a discrete, time frame, and then over the course of time, is it repeated to ensure that there's continuity of the lessons learned for the classrooms or the students? I mean?
Sure. Thank you for the question. So the way it works is you have to work with all the stakeholders in the school system. So, and we work with each of the HRIs, we'll do that, but you're all the way from the school board, the superintendent, the principal, the teachers, the counselors, all of them. And then you basically identify the school, and in each school, each classroom, and in each classroom, all the students get the program. So it is a multi-layered, but all the students will get it.
Thank you.
So it's theoretically, if one school district, I'll give you an example where the superintendent was very helpful, very supportive, and says, why don't we just focus on the kids who have a problem? That is not the model. This is a model for all the students in that classroom.
Very good. Any other questions?
And just one with Dr. Martinez, I think that the advantage with this is actually that it does also keep in mind the issues of diversity, because each HRI will then identify schools in all their areas. So we are encouraging strongly, and obviously HRIs are very interested in adopting those schools that are in diverse populations. So therefore, those students will also get it. And we'll keep a track of that and give you metrics on that as we go proceed.
Oh, that sounds great, Madhukar. You did make me think of another question, since it's multi-layered. Does it also include the PTAs, the Parent Teacher Associations?
Absolutely. In fact, what we find is the PTAs are the most essential stakeholders, and we have training programs and materials for that also, because they have to also allow their their children, to provide us the data so that we can keep track of the evaluation, because we don't want to do this if it is not impacting positively their mental health. So we keep track of that, and that requires parents to provide consent.
Excellent. Thank you.
All right. Very good. Well, again, thank you, Madhukar, and I really appreciate the work that you're doing. Why don't we go to the next item, and a little bit of kind of how I'm going to try to manage this meeting. I'm going to keep us going to right around 12, and then at 12, take a 30-minute break. But there's several things I think we can get done before then, and I'm going to keep moving forward. Again, we have a very tight agenda today. So again, we'll plan to break at noon. But let's go to Laura Williams and hear about the Family Intervention for Suicide Prevention Initiative. Thanks.
Hello, everybody. Thank you for letting me talk. It's going to be very brief, similar to a few of them previous. So going off of Dr. Trivedi's conversation, we're using this particular type of intervention to work with primary care physicians in their clinics. So this is a train the trainer model type intervention, where we're going to use the FIST model, which is for emergency room, and we're going to have an adaptation of it to a primary care clinic, provide education to our CPAN teams first that are participating in this program. We have 6 of the 12 HRIs that are participating. Those teams will then be trained in how to implement FIST. And then we will then have PCPs who will be selected to also become trained in using FISP and adapting it in a clinic. And so therefore, what we're hoping to do is actually provide another model, another layer of intervention when a young person shows up at a primary care physician's office with either suicidal or non-suicidal self-injurious behaviors and doesn't know how to help that young person and their family. So that is essentially what FISP is. And just like everybody else, we are in part waiting for the clarification about when the finances will be coming in. We're working with Dr. Trivedi's team in his network. Taryn Mays is helping us lead the charge for the work to adapt the FISP to primary care. And we'll be working with each of those teams to first train their team members and then have outreach to primary care for them to become trained. We will give them CME as well as reimbursement for participation in the training. And so then we will hope to be able to gather data around the effectiveness of FISP in a primary care setting. That's what it is.
All right, very good. Any questions for Laurel? All right, hearing none, why don't we, was there a question?
Just one point. I think this is and thanks, obviously, Laura will explain it, but need to emphasize, this is a wonderful way to expand what the CPAN providers and both at the primary care and at the HRI level can do to expand this critical population need in terms of kids who come into either primary care or a psychiatry setting with attempted suicide, thoughts of imminent suicide. And most of the providers, including psychiatry providers, get a little sort of nervous at that point. So this is really an attempt to try to help that process.
Very good. All right. Before we go to the next item, just a couple of recognitions. Courtney Harvey, I saw you just a little bit ago, and Courtney is representing HHSC here today. I want to make sure that you are welcome. And second, Elizabeth Mayer, this is your first meeting with the Texas Child Mental Health Care Consortium. Elizabeth is taking the position that Stacy Silverman previously had, and the Higher Education Coordinating Board has been a really incredible partner as we've moved forward in these initiatives. And so I just want to recognize you, Elizabeth, and thank you for being here today.
Thank you all. Thank you all for the great work you all are doing. It's just very exciting to see in these times. So thank you so much for everything.
No, thank you. Has anybody else from the executive committee joined us since we did the last roll call? Okay, hearing none, why don't we move to 3C, which is program evaluation of the Texas Child Mental Health Care Consortium and the work of the University of Texas at Austin. Molly, I saw you a little bit ago. Let me turn the podium over to you.
Yes, good morning, everyone. Thank you so much. We wanted to spend just a few minutes sharing a little bit of data. It's been a little bit of time since we've looked at our TCHAT surveys. And I really like this data because it's some of the data that gets us the closest to the individuals that you all are serving. So we wanted to share a little bit of that with you all this morning. We are going to start with what our families are telling us. So this data represents surveys that have come in during this fiscal year between September and the end of January. And these are our various satisfaction items. And to orient you a little bit to the chart, represented in blue are the proportion of responses that indicated that they were satisfied, and represented in red is the proportion that said that they are very satisfied. So if you step back and take a big picture look, you'll see that all of the satisfaction rates are very high, ranging from 90 to almost 100%. So the part that is not shown on this chart, which indicates neutral or less satisfied, is that very small difference between the end of the chart and the 100% mark. So looking at this, I think we can see across multiple items that individuals are predominantly rating, families are predominantly rating that they are very satisfied with services. There is not a significant amount of difference between the different items, but I will point out just a few things. You might notice that the lowest level of total satisfaction comes from the item, I feel that TCHAT services have helped my child or family. That is probably the most challenging item, right, to move, because we are looking not just for satisfaction, but also for the family to report significant changes during the time that you all have families for care. And even that is at 90%, so still quite high. The other thing that you'll see, there's a little bit of variability, so a greater proportion of families that report satisfaction and not very satisfied in the area I participated in my child's treatment. So that's probably an area we're seeing a little bit more variability in how parents are reporting. Next, we have a question that actually asks family members about how they feel like their children are doing at the end of their time in TCHAT services. And you will see here that over half of respondents, families report that their children are doing a lot better. And a significant number, about 35%, report that they're doing a little better. So we are seeing improvement in the vast majority of children as rated by their parents, with a very small percent even reporting that they are doing about the same, and a very small percent reporting that their children are doing either a little worse or a lot worse. We also gather a little bit of qualitative information from our family members. We specifically ask them to give us opportunities for improvement. So we're not just asking in general about how do they feel about services, but we're asking them specifically to please tell us how we can improve. So here are a subset of some of the responses that have come in this fiscal year. So we hear from families, the services have been life-saving for my child. I cannot think of anything to improve on. I'm so grateful for this program. My daughter was in a really rough place, and this program was like a shining light to her. It sparked amazing conversation between my daughter and I. She has some tools in her belt to handle situations she can't control in the future. Thank you, thank you, thank you. We also get feedback, expand T-Chat with more staff so that more families can benefit from this. These services are badly needed across the North Texas in numerous families. So I think families will be happy to hear about some of the ARPA expansions that are planned. I'm grateful for this free service and that it was offered via his school and the counselor. Provide more sessions. Everything was awesome, except that it only lasted 4 sessions. And I will say in terms of critiques, that is the most common one we see, is that families would really like to be able to stay with T-Chat services for additional time. So turning to our young people, we asked young people to provide their responses as well if they are in middle school or higher. And so here are the satisfaction questions for our young people. Again, the chart is set up the same way. We see overall slightly lower overall satisfaction rates for young people. I will say that in other evaluation that we do, that is a common occurrence. Our young people are a little bit more critical than our families are sometimes, both of services, but then also of their own improvement. But we still see overall very high rates of improvement, particularly impressed by the very high agreement with T-Chat staff treating me with respect. Our youth almost across the board felt that that was very true. Lowest level of ratings, if we look at those, are really, again, around feeling certain that T-Chat services have helped them. Again, young people can be somewhat critical of their own and somewhat less likely to see their own improvements at times. And then some increasing variability really in our young people in terms of a greater percentage you might identify as satisfied and closer to those that identify as very satisfied. But overall, I think data that you can be quite proud of. We also ask youth about their level of improvement. And this is demonstrating that as a result of T-Chat services, I am. And we've got just under 40% reporting that they're doing a lot better. And a little over 45% reporting that they're doing a little bit better. And then just about 13% saying that they're doing about the same. And again, a very small number reporting that they may be doing worse. So despite the short time that families may be involved in T-Chat services, I think we're seeing some evidence of some significant progress. From our youth, we asked them as well about opportunities for improvement. Here are a few comments from our young people. Maybe increase the video calls available. I enjoyed my time with the service and it proved helpful to me. More interactive things. So perhaps more opportunities to engage young people in interaction while they're on the T-Chat services. Honestly, everything is great and I love it and really think it helped. I'm not sure, maybe just making things essentially more comforting and easier to share random things and feelings the person is feeling. And then lastly, I don't know, but thank you for everything from our youth. So that is what I was hoping to share with you all today, but let me know if you have any questions. And I will say that I am also taking notes about some of the questions that you had of our existing data around substance use. So thank you for that question earlier.
Very good. Thank you, Molly. I think that's an encouraging report. And actually, some of the items that they listed related to more T-Chat services are some of the things that our institutions are trying to address with the ARPA funds that are made available. And so I think our institutions should be encouraged and proud related to how the people we're serving are responding. With that, Alex, let me go to you.
Yeah, thank you, Molly. I think having regular updates on our internal evaluation is really key to helping us inform where we need to go in terms of progress, adjustments, et cetera. One of the questions I have is, do you have any planned follow-up for the families and kiddos who report that they're not doing the same, they're doing the same or worse How are they doing worse? Just a little bit more information on some of those, small number of folks. But I think that it's really important to glean why they're attributing that they're doing worse after receiving TChat services.
That is a really good question. We recently, as a result of some feedback from the teams, from the TChat teams, started gathering information on those forms to allow families to let us know if they would like to be contacted or are willing for us to contact them to provide some information. So it's not been in place for very long, but we have inputted that into the form so we can kind of have permission for that outreach. Right now, what we do is we feed that data back to our HRIs if we do receive any feedback that suggests that families were less than satisfied, so that the HRIs can contact them as well. But I certainly think our reaching out to find out a little bit more may also be a great idea.
Very good. Thanks, Alex. Shannon, I know you had a question. You want to?
Yeah. Sorry, Dr. Lake. Yeah, I can't figure out how to raise my hand. I know it's been a long time and I should know that by now. I just wanted to make a quick comment how helpful this information is. And I think this is exactly the kind of information that's helpful to go back to the legislature to explain how the programs are working on the ground as we go next session and try to explain some of these are pilots. And so how are they working? So all the programs that we're doing, this is just such helpful information. So just wanted to say thank you to Molly, but also just note that this is the kind of stuff that helps make our case.
Very good. Thanks. Sarah, I saw your hand went up just a little bit ago. Did you have a comment or did somebody else also ask your question?
Oh, I just wanted to say how phenomenal I think these results are and how we should all just be really proud of this. It's those of us who are reviewing this kind of data in our own clinics. I mean, these numbers are phenomenal in satisfaction, and just thinking about all the kids that we're reaching and the families and the comments they're making.
Morning.
Very good. Peter, did you have a comment? Peter Thompson? Okay. All right. Any other questions? Seeing none, I guess the one thing I would ask is to share this data with your staff, the people that are doing the calls at your institution. I think they would love to see it. And I think they should, again, be proud of the work that they're doing and letting them know that we're looking at this kind of information. I think will continue to be helpful as they continue to provide great service to the people that we were entrusted to serve. So with that, why don't we go, Carol, I saw your hand.
I was just wondering if we have the slides in our packet that Luann sent us this morning.
That they are in the slides. And so if you don't have them, we will make them available to you, but they should be in the information that was sent out this morning.
The idea of presenting them to all of our individual site groups is a really good idea. Thanks.
Good. No, I think that'd be great. All right. So we're going to try to do one more presentation before we go to our lunch break. And so Dr. Nemiroff, I'm going to hand off to you. We have two presentations related to the research initiatives, and we'll go first to the trauma initiative that you're leading, and then we'll go to the depression initiative.
Great. Thank you. I'm going to, Nagla is going to do the honors for me here. First, let me start off and acknowledge Dr. Wagner and Dr. Newport, who have worked tirelessly, as have other members of the Hub, Dr. Lieberzon, and the node leaders. And what I'm going to show you is nothing short of spectacular. So we've done something no other state has ever done. We have set up a absolutely state-of-the-art research network using evidence-based assessment at 12 academic medical centers around the state. And when you see the data that we have, I hope you'll be as excited about it as I am. So next slide. We have assessed 1,122 children. So I couldn't be more proud. And what's amazing is you see that orange line, that's the number of children that have been evaluated 1 month after the index trauma. I'm going to show you some baseline data, but you We haven't even begun to dive into the 1 month follow-up, as well as you can see the green line. We have 500 children 6 months out, and we're starting to now see a year out, 154 children. This is by far the largest study ever done of children exposed to trauma worldwide with a longitudinal follow-up. So I couldn't be more excited. Next slide. These are the recruitments per month for the whole network. You see, for a while, we were almost at 100 a month, and we've dropped off a little bit in November, December. Part of this was the holidays, part of it was COVID, but we're certain we're going to be picking it back up. Part of this is also, as you'll hear later, the focus on the 1 month, 6 month, and year follow-ups, perhaps to the exclusion of more baseline visits. Next slide. So I want you all to feast on this, and I got to give the gold medal to UT Southwestern, right? Look at that, 187 baseline assessments, just remarkable. And then as you can see, some of the HRIs had a late start, but I want to give acknowledgement to those that have done extraordinarily well, including our own site, Galveston, Houston, North Texas, just stepped up with a really slow start. And look what they've done recently, just extraordinary. Then San Antonio, Rio Grande Valley, also a very slow start, and they're almost at 100. So we couldn't be happier with how hard the nodes are working. Next slide. So I'd like to show you data because we're all about data. So we asked the subjects, what was the worst trauma you've ever suffered? Not necessarily the index trauma that brought you in for assessment. And you can see here the percentages, accident, having a family friend ill or injured. You see sexual abuse at 15%, then medical, hospital surgery, physical abuse, attack, and then a variety of others. And interesting, and we'll get back to this, some individuals fundamentally said, in spite of what's happened to me, I really haven't had a terrible trauma. That's the yellow bar you're looking at. Next slide. So if you want to know what the state of mental health is for children in the community, I want you to see the baseline psychiatric diagnoses of children who've come into the emergency room or through a psychiatric clinic. And this is really telling and worrisome that 25% of these 1,100 kids already fulfill criteria for post-traumatic stress disorder, which is almost certainly due to their previous trauma, not the index trauma. Then the good news is 20% have no psychiatric diagnosis, and we'll certainly be following them closely to see what percent of them go on to develop PTSD, major depression, alcohol use disorder, or substance use disorder. Again, you see 18% at baseline already fulfill criteria for major depression, which is, a large number. And then you see all the other diagnoses. Autism spectrum disorder, a little higher than we might have anticipated, attention deficit disorder, and then generalized anxiety disorder. Next slide. So we have a publication committee that's chaired by Dr. Wagner and includes Dr. Soares, Dr. Sisler, Dr. Lieberzon, Dr. Newport, and myself. And we have a very rigorous process by which individuals that want to start analyzing data and putting it together for a publication. So we have a long list of folks that have requested to be able to go forward, but 4 have been approved so far, and they're listed here. So Cody Dodd and Karen Wagner, I'm going to show you some of their data because it's going to be presented at the annual meeting of the Anxiety and Depression Association of America. And they're looking at what are the best symptoms to actually diagnose PTSD in children, which has not been studied very well. And then I'm going to show you data from Jeff Shaladula and Paul Rathouse related to how well are we doing in terms of inter-rater reliability. One of the most important questions is, are the raters in Lubbock or El Paso rating subjects the same way those at Dallas or Houston or Austin? And the sine qua non for that is looking at what's called kappa coefficients to see how good the raters agree. And then we have two other publication projects that are also, that I'm not going to show you today because the data has not yet been analyzed. Next slide. So this is from Cody Dodd and Karen Wagner's work with the hub, and you can see that on the left part of the slide is how we diagnose PTSD in DSM-3, DSM-4, and DSM-5. And fundamentally, we looked at additional models, and what we discovered was that to make the diagnosis of PTSD in children, that you have to add two more diagnostic criteria for the best model, and that is anhedonia, the inability to experience pleasure, and externalizing behaviors. Next slide. And this just shows you how we looked at the model fit, and this will be presented by Dr. Newport on behalf of the team at the ADAA annual meeting. The other point, next slide, is how good are we in terms of inter-rater reliability? Have we really trained the raters to a standard that we feel we're comfortable with in terms of inter-rater reliability? How good are we? And you know, the fact of the matter is anything above 0.8 of a kappa coefficient is considered really great. And obviously 1 is perfect agreement between raters. This was done by showing raters videotapes of an interview and having each of them independently rate the subjects. And you can see here in green, we did great. This is as good as any NIH study that's ever been done looking at inter-rater reliability. It sets a standard for child psychiatry that's never been described before. And we're going to be submitting this in all likelihood to either the Child Psychiatry Journal or perhaps the American Journal of Psychiatry or JAMA Psychiatry. Next slide. Which just shows you how remarkably congruent the raters are. And I think that's my last slide. So couldn't be more happy with how the nodes in the hub are doing. And we're already beginning to talk about how to move this forward in the next biennium.
All right, very good. Are there any questions for Dr. Nemiroff?
Charlie, this is great. Remarkable effort.
Well, thank you, Jair. We're excited.
It's nice to see us in the publication phase now.
Oh, yeah, no, we're really,
Yeah,
and that's just
good.
the baseline.
Yeah.
We're going to probably have a dozen publications come out of the baseline, and then we'll start looking at the 1 month and 6 month data.
And as I was kind of looking at those columns, that early on you had 900 some with the baseline, and then the next, when I tried to add those all up, it looked like somewhere around 2,500 encounters, right?
Absolutely.
Am I interpreting that right?
You are.
Okay.
You are, absolutely.
Okay. Very good. Any other questions?
Yeah, I have a question, David. Charlie, can you talk just a little bit, maybe a couple sentences about where you're going with this research in terms of you're looking for recovery? Are you looking for any of the biology markers too?
Well, we haven't collected any biology at this point, and I think that's a subject worth talking about in the future, but I don't think it's for today. We're very, very interested in the future in starting to train individuals at the nodes to be able to actually provide the best evidence-based treatment for children with trauma. There's my own personal bias that the next phase of this work will be training all of the nodes to provide trauma-focused CBT, which is the very best treatment, and then start to look at predictors of treatment outcomes to that very best treatment. There are alternative treatments that we might also incorporate. And, Carol, we're very interested in biological measures like brain imaging and the like. And I think that's something we can explore in future discussions. Okay.
Thanks.
Any other comments or questions? Seeing none, we're going to take a break. We're going to take a lunch break, and we will start again at 12:30. And so I'll start right at 12:30, and see you then. Thank you. We will be starting again in just a couple of minutes, right at 12:30. Thanks, everyone. I will ask our executive committee members as you join us again, if you could turn on your cameras so we can do the quick head count and make sure that we are able to start again. Sixteen, 17. All right. I think we're well above quorum, so we will go ahead and resume our meeting. It's good to see everyone again. Why don't we go to you, Dr. Trivedi, for the update on the other research initiative on depression.
Thank you all. Nagla, will you bring up the slides or do I?
She's bringing them up for you right now.
Well, actually, okay. Thank you all. So it's always good to go after Dr. Nemiroff. I think he has a much better skill at using superlatives that are correct. I have to say the same excitement about these two networks is really worth taking a minute on. The inter-rater reliability data that Dr. Nemiroff showed, we have the same kind for our network. And as all of you know, I've run a whole lot of large multi-center trials that are purely research focused around the country, NIH funded. And even on those networks, inter-rater reliability on raters is not often as good. So I think the networks are now fully functioning and the excitement is, I think, very wonderful. Next slide. What I'm going to talk a little about is exactly what we are doing in the depression network. A couple of things to keep in mind as we talk about the depression network. Two things. One is for depression, we have evidence-based treatments, and we have really approaches like measurement-based care and collaborative care that Andy mentioned. So at the end of my presentation, I'd like to ask Dr. Wakefield if she's still say a few words about all the work we are doing, because unlike, I mean, this is a truly learning health system, and therefore in the process of delivering the research project, we are simultaneously improving the quality of care. And you've heard other PIs on the nodes talk about it before. All the 12 nodes are participating. There's been extensive ongoing communications. Our committees meet regularly. We have one-on-one calls with each of the nodes every week. We have also been visiting individually with nodes to change things, modify things, lessons learned, etc. There are actively total number of assessors trained is 72. The total number of staff trained in the electronic data capture, data cleaning, etc. is 101. Various roles, basically we've trained 150 people around the state that are providing that kind of high quality inter-rater reliability that you just saw. Next slide. Next slide. Oh, perfect. So these are the nodes. We have 1,053 participants consented across all the 12 nodes. Some of the nodes, as Dr. Nemiroff mentioned, started early and they have higher numbers, but we have all of the nodes fully functioning and contributing to this network. So that is the other piece. So a lot of the research networks are kind of selective things where only some people participate, and then there's a whole threshold issue, etc. Here we are focusing on making sure that none of the nodes are dropped. So we are going to actually have a fully functioning network across the entire state. Next slide. And this is the exciting thing. Of the 1,053 consented, we have a total of 4,481 visits, research visits. This does not include clinical encounters. There's obviously a whole lot. And as you can see, month 12, we have 135 people. Month 6, we have 475 people. So the kind of longitudinal outcome data across the state, across various racial, ethnic groups, and rural, urban areas is really what this network is beginning to produce, and we'll give more data as we go along. But this is really now giving you a sense of, we have about close to 4,500 research visits already conducted. Next slide. Our goal has been to get to 1,800. Our current, especially with the pandemic recently, our numbers went down a little, so the average number enrolled is 4.2. We are asking all the nodes to get to a higher number, and a lot of nodes are beginning to do that. Our goal is now to 6.75 per node per month. That means some nodes will do 8 and some will do 6, and etc. But we'll get to the target at 1,800. This is something we use to talk to each of our nodes to try to make sure we are participating as a group. And some months, some places have lower numbers, some places have higher numbers. So we are actually aiming to get to the full number. Next slide. These are the other attractive thing about this is that since we have spent a whole lot of time training coordinators who seek consent and assent from the participants, our dropout rates are very low. You can see attrition rates range somewhere in the 8 to 10% range. Month 4, 10% attrition is well below the numbers that most large-scale trials in the US are conducted on, or Europe for that matter. Next slide. And even up to 10 months, 12 months, we are still ranging in smaller numbers of attrition. Remember, for the depression network, we have many more visits, research visits, and so from time to time, convenience, etc. There may be some, so you can see here at 8 months, fewer people gave us, but then by 10 months, we were able to go back to them and ensure that they're providing us the data. So in terms of looking at trajectory, etc., some of this wobble is to be expected and doesn't hurt in terms of our data analytics. Next slide. We are maintaining a fairly good distribution with 10.8% African Americans, 13% American Indian or Alaska Natives, and 65% white. Our Hispanic, non-Hispanic population has remained somewhat stable with our recruitment, so that about 44–45% are Hispanic. Next slide. In terms of severity of the population we are seeing is actually remarkable. Of the population that is enrolled, almost 70% have at least moderate to severe depression that would require immediate treatment. This isn't a group where anybody would say, let's wait and watch. That would not be a recommendation from anybody. And so this is where I was saying we dovetail the research enterprise with improving quality of care, providing this information to the clinicians, and automatically helps. And then we do training on measurement-based care and collaborative care. So I think this is really where this is that very core principle of learning health systems is an example here. And you'll see that with the next slide with anxiety, suicidal thoughts. So about a quarter of these population that we are studying have significant enough suicidal thoughts at baseline. So this is not, again, a population you can kind of do usual care. You have to be thinking. That's why Dr. Williams, the idea of the FISP in these populations, these providers, we can actually incorporate over time because that is the group that may benefit from something that's much more aggressive for the suicidal population. Next slide. This is also anxiety. So about 60% of patients experience significant enough anxiety. And I think this is another area that I think we are beginning to look at some of that data is going to be very interesting. And I'd love to hear from Israel on this because there is a subpopulation of patients, especially in the teen years, whose primary issue may be anxiety while they have depressive symptoms, and how best to address that. I think we have not really done a good job as a whole field for teenagers whose primary problem may be anxiety, but also have depression, how best to deal with it is, and could be one of the factors that is associated with this ever increasing depression and anxiety rates and suicide rates in the United States. Next slide. So we are a depression network, but we do, as you can see, anxiety, suicidal thoughts, and trauma. So 70% of population that we recruit have significant trauma history, and our most common events are sexual abuse, somebody very close, generally a parent dying or severely ill, physically abused or attacked, and some of the other, including family violence. So these are the factors that are, at least in the history of these patients, who come for treatment. And this, unlike the trauma network, this is just to be clear, this is not at the time of the entry into the protocol, this is by history. And we have data on how soon before, how much in advance they have been traumatized, and we can look at that at a separate time. Next slide. We also have really taken this idea of trying to help nodes improve the quality of care very seriously. So therefore, we have developed a very elegant interactive dashboard that gives real-time information to improve quality of care, monitoring, complete research data, etc. This information is essential for us to have best research data, but also provides a very good tool for any clinician who wants to find out what is happening to their patient on that day. Next slide. And they can actually direct their visits and the decision-making at that point. And we have provided measurement-based care tools for that, but this is one way they can monitor it. Next slide. And really clearly make a treatment decision. For example, this patient coming in January 2021, when they came back between January and July, when their PHQ score was 19, you would imagine they would have done something to improve their care as in treatment, so that they can be brought down. So that is the kind of thing we are trying to actually provide to clinicians so that they can use it in real time. Next slide. And so then I'm going to stop and see if Dr. Wakefield, if you have any comments. And I have to thank too many people, so I won't name all of them because Dr. Liberzon, Dr. Soares, Shauna Clark, and my team with everyone, but Holly Slater, who's our project director, has done a fantastic job. So, Sarah, Dr. Wakefield, any thoughts, comments? Otherwise, I'll open up for questions.
Yeah, I think I just want to reiterate mostly what Charlie said, what Dr. Mimroff said in the first presentation about trauma, that these projects really are changing both how we look at kiddos who are presenting with these symptoms and also how we'll intervene over time in giving us an understanding of what's going on across our state. And I think it's just a privilege for all of us to be a part of it.
All right. Any other questions or comments? Seeing none. Oh, there's Carol. Dr. Dominga.
Duker, you and Sarah just were talking about how there might be differences across the state. What have you observed about maybe a city versus rural or north versus south, or what are all of your findings the same all over the state, or are there some regional differences?
So we want to get a sizable proportion, Carol, to go through the first 6 months before we look at that, because otherwise you get partial data. So we don't want to mislead ourselves. So that isn't something we've yet started doing.
Okay.
I will say that there are appreciable differences between the network sites, the nodal sites, and that has been something that has been a lesson for both networks, I think, in understanding the differences across the HRIs in the research infrastructure, and also just access to care and service delivery infrastructure. And that alone has helped us understand the scope of the problems, whether it's in the Valley or in West Texas or in Dallas, and how they differ. And it will help us change implementation of care over time.
Thank you for pointing that out. So Carol, I was answering about patient level. What Sarah is talking about is actually already something we know, because there are, for example, in very urban and nodes with some history, they may have a clinic that is very vibrant and has hundreds of patients coming. For them to recruit for this is very different from a rural clinic node where it's a small clinic with very few patients coming. Then they have to go out into the community to recruit. And so there are clear differences we are already identifying, yes. And that requires a different setup. So it's not like just saying, go and recruit. That place needs a different level of clinic, and not only clinic, but community engagement and more flexibility and difference. And Dr. Bryant can also comment on it. We visited their clinic, and it's a different setup than, say, Austin or Dallas.
It really is. Thank you, Dr. Trivedi. And one of the things we are actually hoping in Thailand, we're trying very hard to open an outpatient child psychiatry clinic in April. So that may make our efforts a little bit more fruitful. But yes, lack of availability of care in this area is a huge issue. So thank you so much for that.
I actually, as a test, asked somebody at one of the nodes, not there, what would I do if I moved there and my 16-year-old has depression? And the colleague says, that's the problem. So.
All right, any other questions? Hearing and seeing none, thank you, Dr. Trivedi, for the ongoing work, and thank you for all the work across our institutions to stand up both of these initiatives. Why don't we go next to the external evaluation of the consortium and to Dr. Laura Savas. Laura, I think I saw you just a little bit ago.
I'm here.
There you go. Turn the podium over to you.
Outside. So we had slides, but we're going to do a high level overview, and we do have a lot of data that we analyzed from the year 1 and year 2 in our evaluation. We're going to be building on that, but just to kind of give you a high level overview of where our focus has been. We've been really evaluating the initial scale up of the program and processes used for clinic and school enrollment by the HRIs, really doing a detailed process mapping of strategies used to engage the different stakeholders and potential users at the different levels. And that has served as our benchmark for implementation strategies that we will be evaluating in an ongoing basis. And we also have done this by each HRI, by each school, on the school level, at CPAN and the TCHAT level. And we are very happy to meet with HRIs to go through the different process maps that we were able to develop with our from our interviews with the different users. Those process maps also help us with the process monitoring that we'll do in year 2. And that will look at what strategies have been more effective in engaging and first enrolling and then engaging the different users, and to help identify some best practices we've also met with Dr. Williams with these to get feedback on what they've been trying to achieve in their meetings, and helping give this feedback to Dr. Williams so she can use it in her conversations. And then we have logic models that we use to also guide our use of the trait data to identify the metrics of the use of the system. And these metrics we're refining in year 2, and also helping to give us some insight into what trait has and what trait doesn't have. And so trait has been built to guide implementation. And of course, we're using trait data for evaluation. So there were some things that were missing from an evaluator's perspective, and we're in conversation weekly about that. And we've really developed a feedback loop with the trait developers to try to give them some feedback from our evaluation perspective. So really, we'll continue to monitor the program scale up, implementation processes, as well as use of services. In the year 1, we did look at delivery of services by HRIs. After looking at the clinic engagement and adoption of the program, we looked at use of the program, and we looked at it by different characteristics at the kind of geographic high-level characteristics, such as vulnerability indices that look at geographic region, rural versus urban areas, to see that the program is reaching the medically underserved in terms of geographic characteristics, as well as some socioeconomic characteristics that we're able to get from public use data. We're continuing to refine this vulnerability index, and we've added another member of our team who has expertise in this area of spatial analysis and using these data. So we'll continue to do that. So we're also using this information that we use from trait to look at what kind of services are used, how does it vary across HRI, how does it vary by characteristics of providers calling in and characteristics of the patients they're serving. And so this, we've also been, it's a lot of data to communicate back to everyone, but we're slowly communicating it back through the COSH meetings. And they've been really helpful in giving us insight into other questions we can ask in year 2. And we'll be meeting with Dr. Lakey also to go through the findings from year 1. These findings are also guiding our year 2 goals and objectives for our research questions and our logic models. And so in addition to using trait data, we've conducted interviews with the CPW program users, as well as the different school and clinic users. And Dr. Peskin was going to talk about our surveys. So I don't know, Melissa, if you want to take it from here.
Oh, sure. So so we did in year 1, we surveyed clinics and we surveyed schools, and we worked really hard to make sure that we could engage a diverse sample of clinics and schools across the region so that they represented the current participants in this initiative. And also we looked at how it compared, especially for schools, to demographics from the Texas Education Agency as well. We looked a lot at factors associated with implementation, engagement with the program, and we used some implementation science models to really try to understand those factors that are associated with implementation. We found that a majority of CPAN users that were surveyed were using CPAN services, and found that those clinics who reported at least one call reported more favorable CPAN motivation, so higher relative advantage of CPAN, lower complexity compared to those clinics who reported no calls. We also had some really positive findings related to the proportion of providers who felt that their knowledge, skills, and competence had increased as a result of using CPAN, and vast majority said that they would recommend CPAN to others. We also had TChat data as well, and vast majority of campuses there as well reported implementing TChat. In terms of perceived outcomes associated with TChat, I think it's still a little bit soon to sort of assess the school staff's knowledge related to how they felt TChat would impact their students. We did find that about up to a half of participants reported that because of TChat, students had more positive outcomes related to better attendance, decreased behavioral incidents, but many reported that they didn't know yet whether TChat had impacted those outcomes. But a majority did say that TChat increased school capacity to meet non-educational needs of students. And so we'll be building upon these findings in year 2. We'll be surveying another 100 clinics and another 100 schools in year 2 to continue to assess their attitudes and needs related to TChat and CPAN. And I should also mention that we also had some qualitative data that we collected from the TChat users and CPAN users. And we're hoping that in our presentation with Dr. Lakey, we'll definitely share some of those quotes, really some phenomenal things that were said about the programs in terms of how helpful these programs were in terms of bringing these services to youth. So we've got some really rich qualitative data that we're excited to share as well.
Very good.
Laura, do you want to talk?
Go ahead, Laura. You're muted, Laura.
Was it the year 2 logic models? And
yeah, I didn't know if you wanted to say anything more about that.
yeah, just so we have synthesized a lot of findings from year 1, including what we have in terms of implementation outcomes versus outcomes from services, and what we have from trait data and other potential sources. So we've been refining our logic models to really have them reflect the availability of data we have to measure outcomes, and also to help highlight some suggestions we may have to enhance some of the outcomes that could be available to us for future evaluation. So the logic models has been one of our focuses of really setting up the framework for our year 2 evaluation, and we'll also review those with Dr. Lakey and the COSH meetings that we go to get feedback from all of you, some of your perspectives on these. But we'll be reporting outcomes from those as well in these meetings.
Very good. Dr. Trivedi, I see your hand, and then Ms. Wesley, we'll go to you next.
Thank you. Wonderful evaluation. I have a quick question. We have a network with providers doing measurement-based care, and we've obtained similar input. And one place where we sometimes run into trouble is those people who are not using the services, how to find out why not. Have you been able to do any of that? Because those who use it then get the input. But
And that's a great question. And so our survey data does get to that, because we have users and non-users that have been respondents. So like an example of that might be they had a local expertise, and so they didn't think they needed it, or the need didn't arise in that period of our evaluation. So those were just some examples of the use and non-use. In terms of not knowing about the program, that the awareness may have come up, which helps us look at the strategies we've identified in our process mapping to say, okay, are these used across all HRIs in the same way, and what might be some other practices to increase awareness. But the survey data do help answer some of those non-user questions. And if you have suggestions for questions, we're always welcome that.
Very good. Ms. Wesley?
Thank you for the presentation, wonderful information. But Dr. Savas, and I may have missed this in the beginning of your presentation, I don't see the data or the presentation there yet. So when do we have access to that? And this is actually wonderful information, including the evaluation of the internal programmatic outcomes to also share with our teams?
So we sent the report to contacts with that we've been in communication with, and I think that it gets sent out from there after we've reviewed it. And we're also, you know, happy to help go through the data also if people want meetings with us to go through it. I don't know if anyone else wants to add to that, but.
So it's distributed to the teams, and so I can get the information. Thank you.
Yeah, this is Lachelle Inman. We have a meeting scheduled to provide a high-level presentation to Dr. Lakey in the next few weeks, I believe. And so that's kind of the first review internally, and then we will work to get the information distributed out to the HRIs.
Perfect, thank you.
All right, very good. Any other questions? Hearing none, let's move on then to item number 4. But before I do that, Dr. Savas, thank you and your team for the ongoing work. It's really helpful to us as we're trying to learn lessons and make this really a great program for the people we serve. So let's go on to actually item number 4, and a little bit of background on this before I jump in. Last year, we decided that we needed to make more dollars available for the recruitment of participants into these 2 really, I guess, state-of-the-art research initiatives that we have going on right now. That one of the challenges was to make sure that we had the dollars to incentivize individuals and keep their participation in these studies throughout the duration. And I think we've seen today that we have good retention in each of these programs. The leads for these 2 research initiatives came to us with a challenge that they're wrestling with. And I think there's a couple of components of this. One, the really high performing the institutions that are really recruiting a large number of individuals are having a challenge in meeting the need to have the dollars to recruit individuals. They can't dig into their base funding in order to keep individuals recruited, and so are more reliant upon these additional dollars we made available. And we also learned, and Jeff, I want to thank you for bringing it to my attention, that some quarters, even though we have that problem, we're underutilizing some of the dollars that are available. And thus, we wanted to be a little bit more just kind of straightforward with how are we using these dollars. And I told folks that I think this is something we need to bring to the executive committee versus having the research nodes having to and the hubs having to figure this out by themselves. And so I've met with the leaders of the 2 initiatives over the last week. We've had several good conversations, and I think this has been helpful to put some additional structure in place. So we want to go through that structure with folks today. And if everyone is agreeable to that, put these additional kind of guiding principles in place to make sure that it is very clear on how these dollars to be used for recruiting individuals into these studies shall be allocated across our institutions. So if we could put the slides up, just have 3 slides here to talk through what we're thinking through right now. Okay, go to the next slide. So this is the proposal for research hubs. I'm going to try not to read through this, but I think it's important that we go through the details. And thank you, Lachelle, for putting these slides together. And again, these have been presented to the research leaders and of the hubs, and they have agreement that this will help them make sure that we are as best stewards as we can be of these dollars and make sure they're fully utilized. And so 4 major components of this additional guidance. One is that we need to separate participant reimbursement budgets into one per hub. Instead of just saying that there's 600,000 in a single pot, give each of the hubs the $300,000 for participant reimbursements. And some of there'll be a few little differences between those two, but we want to make sure that we are supporting each of those research hubs, and that those dollars will then be divided into quarterly amounts to be used. And so anticipate how many dollars should we use each quarter and make sure that we fully utilize that amount of money. And so we have a method of reimbursing individuals by the number of individuals that come in, but we're going to supplement that to say that at the end of each quarter, we look at the total number of participants in each of the hubs. And if there are unused dollars that we using proportionality, provide those dollars to the HRIs so they can get a head start on recruiting the additional subjects that they're going to need, additional participants they're going to need over the next quarter. We're also going to increase the, just notified my battery's going low, which is surprising because my PC is plugged in. So I will keep going though. That we're going to increase follow-up visits from 12 months to a total duration of 24 months. We've had some discussion of that before. And so they'll be followed for the 24 months. And so we need to take that into consideration. That to change the recruiting targets associated with reimbursement, that the nodes will be reimbursed for participant payments made for any visit beyond the 12 per quarter target for months 1 through 12. Any payments made for visits beyond 12 months will be fully reimbursed, again, using this allocation method. And that the reporting of the hubs and the nodes, that the research hubs will provide UT System a monthly report outlining the recruitment numbers and associated visits. Each HRI node will fill out a reimbursement template that would be to confirm payments made before they are reimbursed. And so again, a role of UT System and the hubs in this process. But we also want to make sure that these dollars are being fully utilized, that we're not in a situation where we're wasting dollars while we're also having institutions that are having trouble recruit at the same time. And we think that this additional guidance will be useful to make sure that we're, again, being the best stewards as possible. If we go to the next slide. The next slide, we're going to change out my power here real quick. Sorry for my distraction. But we're going to, and actually, Michelle, can you walk through these components here, these bullets?
Sure. So we talked about having a quarterly allocation amount for each of the quarters. So whatever remaining funds were in that pot, we would divide it kind of equally at the beginning of the reimbursement cycle. And then reimbursements would be made to the HRIs based on payments where they exceed targets like we talked about previously. So any beyond the 12 per quarter for months 1 through 12, anything beyond that would be reimbursed. And then anything beyond the 12 months would be reimbursed fully. Now, if the HRIs don't fully utilize the amount that's set aside for that quarter, any remaining funds would be allocated back to the HRIs based on performance to cover the costs associated with that increasing recruitment. So the performance percentage would be calculated based on that HRI's percentage contribution towards the overall participant compensation for that quarter. So we have a pot of money, payments are made to the individual HRIs based on recruitment numbers. Any funds left over get dispersed to the HRIs based on how they're performing. Now, if we did have participant payments that exceeded that pot of money, then we would have to recalculate what that quarterly allocation was moving forward. But there would never be a situation where people recruited beyond their targets and they didn't get reimbursed for it.
Okay. All right, very good. Say about this, or Dr. Trivedi?
Perhaps Dr. Newport might want to weigh in. I think you did a great job, the two of you, in summarizing it.
Real good. Yes.
Okay. So again, bottom line, we want to make sure that we divide up the dollars between how much we expect for each of the hubs to use. We also divide up on a quarterly basis how much money those hubs should use during that quarter. We have the allocation methodology to reimburse individuals above their expected amount. And that at the end of that quarter, we look at the percentage of the people that have been recruited to participate, look at it not by HRI, and divide up the remaining dollars and allocate it proportionally so they can get a jump start on recruiting individuals over the next quarter to participate. And that on a regular basis, that information is provided to the hubs, but it's also provided to UT system to make sure we're all on the same page. Any questions? If not, I think this is one of the things today that we need to have a motion on and then vote on to make sure that it has full approval of the executive committee. And so
moved. Second.
Dr. Polowitz, and then Carol, I think I heard you a second.
Second.
Okay. Any further discussion? Hearing none, all in favor signify by saying aye.
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 Opposed, nay. Anybody abstain? So it has unanimous approval, and we'll go forth and use that methodology. Okay, very good. So let me check and see if our guest is here. Ryan Van Ranhorst is going to join us, and I haven't seen him yet, his video come on yet. So I'm going to keep watching for him. He has information related to the work that they're doing with HHSC. But I don't want to waste your time. And so we're going to jump into item number 7 and go through a couple of those items. And if I see that Dr. V, as he likes to be referred to, has joined us, we will divert and go to that presentation. But we'll start going through the update from the Kosh and Dr. Williams. I'm going to turn the podium over to you.
Okay. Hello, everybody. Welcome back. Let's see. Can you see the slideshow?
We can.
Hear me. Yay. So kind of keeping with the theme that I've seen with the other presentations today, I see Kosh is going to maybe show a little bit different information that we've shown in the previous months as more people have been asking questions about CPAN related to who's being served, what are we doing within the calls, and the same thing with TChat. So we're going to look at some things that are a little bit slightly different than how you normally see from us. This slide. Okay, so we're going to go through some Kosh updates and then again talk about CPAN and TChat. And I did put this a little out of order because we'll actually do data governance kind of in the middle. So from an update perspective for Kosh, we've been working with Lachelle and Nagla and Luann quite closely. And one of the things we wanted to do was there was certainly confusion because things were kind of kept in multiple different places. So that was frustrating for teams and was making it hard to have some better integration about processes and programming. So we have moved with Lachelle's help, pretty much all things over to Microsoft Teams. Lachelle is working to build the channels for each of the major initiatives for Kosh, because we only really focus on CPAN and TChat. We're most focused on that piece of it. But we sort of are working to make sure that materials related to the various meetings that people have at an individual HR level, as well as across the communities of CPAN and TChat, that information can be readily found within the Microsoft Teams environment. So that is sort of rolling out as we speak, and so far so good. We've also been working on a manual for CPAN. Maybe after that we'll have the energy to have one for TChat as well. We've had the first draft of that go out to the HRIs. There was a lot of feedback from both the evaluation teams, both internal, external, Lachelle, Luann, and Nagla, and then obviously the HRI teams themselves. So we are in that process of looking through the feedback that we got about this first draft of the manual, making those changes, and hopefully we'll iteratively bring that back to the teams. Hopefully by the end of this sort of fiscal year, we'll have the manual kind of completely realized. The goal with the manual is really to have everything related to CPAN and how it should function and operate should be able to be found in the manual, so that as teams are working to have a consistent way that they manage CPAN, and as they onboard new team members, they can use that manual to do that process and make sure that we stay. Speaking of the earlier topics with the research, I don't know if we can have the same K coefficient that you guys were talking about in research, but we certainly are trying our very best to have a great deal of consistency about when a CPAN caller calls, regardless of what part of the state they're in, they will get the same quality care and recommendations no matter where in Texas they call us from. So that is working its way through that process. And then we're also extremely excited that we finally were able to, with all of your help and support, we're able to hire our new team member for Kosh, the person we've been looking for the last 2 years almost, our senior data analyst, Romel Walker. So I kind of skipped ahead because we were just too excited. I didn't want to put it at the very bottom. Dr. Pliska and Vo, who chair our data governance committee, wanted to make sure that we were going to highlight that we had finally found this exciting new team member for Kosh and for the overall consortium. So Dr. Pliska and Vo continue to run that meeting for data governance. It meets weekly, and we were just extremely excited to have Romel Walker be in this role for us. This is an actual slide that he created for himself, and he allowed for me to share it with you guys today, but he has a deep and longstanding expertise and interest within the sort of fields that touch mental health and children's mental health. And so we're just extremely pleased that somebody with this much qualification and experience and enthusiasm has joined our team. And he's already started to kind of look at the data, starting to work with it. We'll have much more to say from a data perspective as we move forward. He just started in January, so we're doing our best to not overwhelm sort of his, asking him to analyze everything all at once, but we're just very excited to have him here with us at Kosh and for all the help he's going to provide us across the state. So I'm now going to talk CPAN for a few minutes and then TChat. So wanted to alert you to, speaking of Melanie's communication at the very top of our meeting, one of the big things that obviously CPAN is for is not just specifically the call that comes in by individual provider, but the outgoing education and outreach that we do as each of the CPAN teams. We started our project ECHO. For those of you who are not aware what ECHO is, it was initially started in New Mexico for treatment of adults with liver disease, and it has now spread out worldwide. It's been up and running over 10 years now as a system. And it now has almost every kind of specialty under the sun has ability to have developed content for ECHO. But ECHO is a sort of a community-based learning process with experts across the state. So I thought CPAN thought it was very well suited to use ECHO as a model of outreach and education to primary care physicians. So we did our fall launch of ECHO, and the team did an amazing job, very quickly turning around even on top of CME activities they were already doing to do this process. Speaking of trying to have a consistent message, all the 12 hubs recruited PCPs in their local region. We all provided the same content when it came to the sort of topics of conversation for each of the CME activities. And then within an ECHO project, you do a brief presentation on a topic, and then you have 45 minutes or plus to do a case consultation process where the PCPs would bring questions in advance of the meeting. The CPAN teams would be prepared to answer and then guide a conversation with those PCPs. So we felt like the fall launch went very well. We've been in organizing with TPS and Dr. Nguyen's help to sort of decide on the topics that are most wanted by primary care physicians and related to children's mental health. So we're pleased that our April will launch the start of our spring ECHO session. Our goal is over time to actually continue to have a fall spring cadence to the ECHO project. Again, the goal of ECHO is to be short and small teams. So we don't necessarily want 100 providers in an ECHO meeting necessarily. So we do think this will be something that we'll be able to continue to provide for primary care physicians across the state for a number of years. And it also will help solidify our own individual validity about the things that we're recommending as from an evidence-based perspective when it comes to children's mental health. So we're very excited about that. Our spring session is going to include 6 topics. Again, these were topics that were vetted in primarily with our TPS partners. And so we're just excited that's getting ready to start up in the near future. We also continue to work, as others have suggested, on the ARPA program and projects that are getting ready to launch themselves. To the conversation that we've had around communication and outreach, as well as what things might need to change within the TRAIT platform, both from an evaluation perspective, as Laura suggested, but also just as the programs themselves launch. So we've been working with that process very closely to make sure that as those new federally funded programs launch, we can gather the appropriate data from a programmatic and evaluation perspective. And we are working with TPS again. Once again, they're going to help us with a pilot to pilot the direct text messaging process first before we go live across the state. And we are continuing to work on the processes and that we'll need to put in place to have direct consultations for CPAN. So those are the things that are working on right now. And then as the PeriPan team kind of lands on what they need and want, COSH is going to be there to support that process as well. So for CPAN, this time we decided to kind of spend less time on the dashboard. We think you guys have seen that dashboard plenty of times, and a lot of times your questions end up being things that are not related to the dashboard. So we just wanted to do the high level conversation today with, we have over 7,000 providers across the state of Texas enrolled in CPAN currently, with over 1,300 clinics. To date, as of the end of January, we had over 7,000 completed consults on an estimated 6,200 young people. And we continue to hold strong with our metric of returning the provider's call within 30 minutes across the state, because again, that was one of the big key uptakes across other state programs nationally, is that if you have a quicker turnaround time for the PCP to be able to speak to a child psychiatrist, there tended to be better utilization of the service. So we're glad to see that we're able to continue to meet that bar. And you do very well there. The next 2 slides I'm going to share are actually about the types of concerns that PCPs are calling CPAN on. We do want to remind everybody that CPAN is not a crisis center. We're not an emergency line, but we do collect the nature of the call and we certainly don't want to turn away a person if they're calling us. But we do have a process that if a PCP calls and they themselves have decided that something was urgent or an emergency, we have a script that we ask our CPAN team to tell the PCP to make sure that they activate their own internal emergency systems for when they're calling if something is about a crisis. But one thing that often happens is that, they already know that they should maybe call 911 or send somebody to the emergency room, but many times they're asking a follow-up question. Well, what do I do when the family comes back after they've gone to the emergency room? So we still find that there's ways for our team that can be providing appropriate education, even if we have to be clear that what we cannot do is provide emergency services. So I just wanted to make sure that I said that before we talked about some of this information that I was getting ready to share. So when we look at our calls, those 7,000 calls that we've had since the inception of CPAN, you can see here that the majority of the time, the primary care physician is calling about things related to anxiety, sad mood, or depression. Because these are chief complaints, they can sometimes be, for example, sad mood and depression are similar, but obviously these are the specific words that the PCP had said, and so we had captured in this particular way. And this should not be any surprise to you who've listened to the Trauma and the Depression Network's research outcomes, but PCPs are generally calling us with pretty difficult problems. They're not calling with necessarily mild to moderate concerns always. They're definitely calling with families that are in distress. So we also do see them calling specifically around aggressive behaviors as well as suicidal thoughts. So again, reminding, this is chief complaints. This is what the PCP is telling us they're calling that they need help for. This is not what our team is doing in response. This is what the PCP is saying, hey, I need help with these particular problems. As we get this data looked at in more detail, one of the things that we can also use this data to help us with is to do the planning around CME activities, around any materials that we want to share or have available to PCPs on our website that Luann's team will be working to work on and improve the communications team's help. So again, this is what PCPs are calling us and needing help with. We do also, if the PCP has provided a diagnosis, now they don't always, because sometimes they're calling us like, hey, I don't know what the diagnosis is. I'm just concerned because of X, Y, or Z. But if they actually call us, and about half of the calls to date have an associated diagnosis with it, then we also record what was the information shared to us, our CPAN team, about what the PCP is indicating was potentially a diagnosis the child currently has and that they're needing help with. And as you can see here, back to Dr. Trivedi's the depression network that's ongoing, how to help those PCPs provide evidence-based care, including potentially using scales as well as algorithms to perform to the perspective of helping that child get better. You can see here that we are called very frequently about young people that the PCP has said has a diagnosis of depression, has a diagnosis of anxiety. So again, these are when the PCP themselves says, hey, this child has this diagnosis and potentially I'm calling you because I need help trying to understand what I can do in my PCP office to help this young person. So I do think that the depression network, as well as the new project, the Lone Star Depression Challenge that the Meadows team is doing, all these things kind of work collectively together to help enhance the skill set of PCPs and provide a place for integrated care such as CPAN. So when I put this word emergency call, I want to be very clear. As I said at the top, we are not an emergency center. We do not communicate ourselves as such, but PCPs themselves will call and say they're having an emergency. So we do just record that this is what the PCP has told us. And then at the same time, we tell them to activate their own emergency processes. We actually discovered, Dr. Trivedi, that they don't often have a process, which is one of the reasons for why we're thinking that FISC was a good federally funded ARPA project, because we hope that if this can be successful, it can start to be a blueprint for primary care physicians to utilize in their office, as well as for our team to have consistency about how we're recommending a PCP consider managing maybe the next case that comes in. Maybe we can't help right then with that emergency, but we can help that PCP think through the next time that somebody might come to their office with suicidal thoughts. But as you can see here, the overwhelming majority of the time when the PCP identifies that, yes, they're calling in something that feels emergent to them, they're calling about a young person as either having active or passive suicidal thoughts, or have been actively or considering non-suicidal self-injurious behaviors. The other category, when we look at the actual text box into other, the vast majority of the time, those are continuing to still be about suicide or NSI behaviors. So again, the vast majority of the time, they're calling related to suicide. Beyond suicide, in the other category, actually eating disorder or disordered eating is often considered often a medical emergency that they're asking for help with, along with kids who are potentially acting aggressive and or maybe have psychotic symptoms. So as you can see here, we want to consider the kinds of education that we can provide PCPs outside of these calls to kind of help them become better equipped to manage the emergencies that may come to them without us being an emergency center. So just thought people might be interested to see a little bit more data and information around some of the information that we're currently collecting as it relates to CPAN. Moving on to TChat. So I'm also going to share a little bit of data from a slightly different perspective related to TChat. We want to talk to you about kids that have gotten a service and completed a service. So this is not the totality of TChat for this academic year. And it's probably even this data will be modified as the remaining data comes in. So this is an early look, preliminary data for young people who had a referral and who were enrolled in TCHAT services between the months of August and October. So we're only looking at a small cohort of the large, much larger actually, group of young people in TCHAT for this academic year. So as you can see here, we have 3,442 young people that were referred and had an enrollment in a TCHAT service between those 3 months of August to October. Within that 3,442, 2,435 who were enrolled have been designated as completed their service. So you can obviously notice there's a difference between those two numbers. But what I would want to be clear about is that we're still gathering this data. So that number, both of those numbers might be likely to change, but we still thought it was good for you to sort of see some information around those 2,435 kids who were enrolled in TCHAT in that first 3 months of school and whose services have been put to, now they're at the end of care for TCHAT. What can we start to look and see about the characteristics of those young people? The reason why we picked this sort of first school quarter, not fiscal year quarter, to Lachelle's point earlier, is because we imagine that these kids were more likely to be the kids that have completed the service, because TCHAT is an urgent short-term service, not an ongoing service, such as the trauma network or the depression network, which can go on for months. So we felt like that there was a better chance that we would see a larger number of young people who were completed, and then we'd be able to maybe say a little bit about what those young people are looking like as far as the care. But again, we do think this is very early, very preliminary, and we do expect this data to change as the school year winds down and we get kids completed with their services. So for those 2,435 youth, again, there can be multiple reasons. So this is not meant to add up to 100%. Most of the time when the school makes a referral, they often are clicking more than one reason for a referral. But as you can see here, the most common reason for a referral into TCHAT services for those 2,435 youth are related to both anxiety and depression. So again, this goes back to the data you heard earlier this morning related to depression, anxiety. But you can also see that there is a significant number of youth that are also being referred for both self-harm as well as suicidal thoughts, with the 517, 573, as well as related to trauma. So again, across the gamut, young people that are being referred to the services are definitely in distress. And certainly I'm glad to hear that, because first I'd heard the data as well, that the families that are responding to the evaluations team's perspective on that the services were helpful to them, that was certainly good to hear. And I'm glad to share that with all the teams. When you look at the types of sort of interventions that our teams in TCHAT are doing with the young people that have been referred in, those 2,435, again, you can see sort of a breakdown here as to what we're doing. It's not uncommon. So you can see here that the largest, one of the pieces of the pie is around supportive care. But there is also a healthy slice of people who we're needing to provide crisis management for. So speaking again to those ideas about how do we help our own team make sure that we have an appropriate response to young people who are having suicidal, self-injurious thoughts or whatnot is also, I think, extremely important. And again, you can sort of see that we're providing a variety of services based on the sort of individual needs of the children and family in TCHAT services. This is actually this question has been asked a couple of different times, is sort of like, well, how many appointments are young people having? What does TCHAT services look like now? As we all know, the TCHAT services are meant to be around urgent and brief. So we have defined that as an evaluation plus 4 visits afterwards. So we wanted to see for those kids who their services have ended, and that's that 2,435, what was the number of appointments that they were having? As you can see here, the most common number of appointments that they were having was 2 at 1,786. And then again, when you look as far as 4, or what we say is the 5 is the total number that is defined as a sort of the classic, TCHAT classic, was 900. We do still, from a clinical perspective, if a young person cannot find, if our team can't find them an appropriate care referral afterwards, or if our team is providing step care, or just thinks that 1 or 2 sessions potentially could avoid them having to have a referral, teams are given the discretion to see the young person for longer than the 4 or 5 visits. But we do ask that every single time that we see them past that sort of designated TCHAT classic, that they're having to answer a question every single time, why are you extending the services out? And so you can see here that there is definitely some young people that are getting services in the 6, 7, 8, 9 range, but it's obviously a very small percentage of the total TCHAT services in general. So at least at this moment in time, what we can see about this data is that we are providing a service within that sort of designated TCHAT classic of up to 4 appointments after the initial evaluation. When you look to see what types of providers TCHAT for those kids that completed the services, what kind of providers were in their sessions, again, the vast majority of the time, the providers are a therapist, either LMSW, LCSW, LPC, or psychologist. So the vast majority of the time, the young person is receiving a TCHAT service from a therapist and or psychologist. Again, a smaller percentage of the time, they are seeing a psychiatrist. And then an even smaller percentage of the time is when they're sort of having a dual appointment with both the psychiatrist and therapist. So the services, the providers that are providing the services is really what you're seeing here, again, for these youth that have completed their services within TCHAT. So again, I told you I was going to do a little bit of a different look today, and I also know that Dr. Lakey had a sort of tight agenda, so I'll end here, and if you have any questions.
Thanks, Laura. We do have time for questions, and so if people have any questions, I think this was very helpful, and again, marking it out with TCHAT, not only the number of folks but that we're serving, but the number of times really shows the volume of work that's being done right now. And so, are there questions for Dr. Williams? Well, I guess, Laurel, you told them everything that they needed to hear right now. So very good. And as we go forward, if people have questions, we can come back to that. But again, a lot of work taking place throughout the consortium right now. So with that, I'm going to do a little detour here on the agenda. It looks to me that Dr. Van Ramhorst has been able to join us. I see him. Ryan, great to have you here. For those of you that don't know, Ryan, I'm going to call you Dr. V, because whenever I go to HHSC, if I'm not referring to you as Dr. V, they don't know who who I'm talking about. But Dr. V, for those of you that don't know him, is somebody you should know. Dr. V is a pediatrician that I got to meet when I was working at the state. He was a very respected pediatrician down in San Antonio, involved in a lot of policy work with the Texas Medical Association. And the Health and Human Services Commission decided that they needed his talents at the state. And so he is now the medical director for Medicaid at HHSC, as he also does clinical practice down in San Antonio on a part-time basis, and balancing administrative work plus his clinical work, so he can make sure that the policies that he's putting in place in Medicaid are realistic and are doable at the practical level. And so the work of the consortium, Ryan and I have talked about many times in a lot of our work with the perinatal work. We have been discussing, how do we put these programs together? How do they interact with the current Medicaid programs? And he has been extremely helpful. And so with that, Dr. V, Ryan, I'm going to turn the virtual podium over to you and let you talk through some of the things that you've shared with me recently that you think would be interest to the consortium.
Great. Thanks so much, Dr. Lakey, and thank you for the warm introduction. It's great to be among colleagues. I did want to call out that two individuals that I see, Dr. Pliska and Dr. Blader, helped train me when I was a resident and fresh out of residency practicing on the south side of San Antonio, and provided support through a CPAN-like initiative that was funded by DSRIP dollars, the Delivery System Reform Incentive Payment Program. And so it's great to see both of you and all of you on this meeting today. So I know one of the things that I was asked to come speak to you all about is the Medicaid Autism Services Policy, which is where I'll focus most of my time. And there's lots of other really good things going on. I'll mention a few highlights and then hopefully have some time for questions. I don't have a slide deck if that's okay, but I do have some talking points that I can send out to the group later today. So the Autism Services Policy was actually one of the things that I came to HHSC for. This has been a long time coming. Our Medicaid Autism Services Policy went into effect on February 1st of 2022, so just about a month ago. And this policy covers applied behavior analysis. That's one of the new things that is now a covered Medicaid service. Texas is one of the last states to bring applied behavior analysis as a covered service, but we're there. It is called a Medicaid Autism Services Policy and not an ABA policy, because we recognize that for individuals with autism spectrum disorder, a holistic approach is required. And so our policy also details other services that are already covered that also could support children, youth, and families impacted by autism spectrum disorder, ranging from speech therapy to occupational therapy, behavioral health services, etc. The policy also unlocks a new interdisciplinary team meeting where the licensed behavior analyst who's providing the ABA would be financially compensated to participate in a team meeting with the speech therapist, with the school psychologist, with the service coordinator through the Medicaid Managed Care Organization. And so hoping again to make sure that that child is surrounded by a suite of services, not just applied behavior analysis that might meet needs of that child and their family. We did have to create and bring on a new provider type in Texas Medicaid, which is no small task. I mentioned that the provider type for this is licensed behavior analyst, which includes board certified behavior analysts or BCBAs. You may know that Texas is relatively new when it comes to our licensing through the Texas Department of Licensure and Regulation. That's existed now for a few years, and so now we have this new provider type. We continue to work very hard to enroll licensed behavior analysts to support a network of providers to meet the need, which we long time, and we finally are in a place to offer this service. Just to level set, Texas Medicaid is a managed care Medicaid program, which means that the state of Texas contracts with managed care organization vendors, many of which you are familiar with. There are 17 of them, and this benefit will be administered through our Medicaid managed care organizations. However, the policy that we wrote for the Health and Human Services Commission must be followed to the letter of the law by our managed care organizations, and that includes things like prior authorization and requirements for that. We do have a very small number of individuals that are still covered in what some would call traditional or fee-for-service Medicaid. But again, the majority of children with autism spectrum disorder are going to be enrolled in a Medicaid managed care program. And I should mention that this benefit is for individuals less than 21 years of age. So it is for the pediatric population. We will continue to monitor enrollment of the licensed behavior analyst. We will start to monitor the number of authorizations that go through, the number of prior authorizations that are approved, that are modified, that are denied, to make sure that children who need this service for which it's medically necessary are receiving it. And really excited for the future. Always appreciate the opportunity to meet with stakeholders such as yourself to make things better. And let me pause there. That was a lot of material, and I'm happy to take questions, and then I'll mention a few other things that we're working on in Medicaid.
Very good. Any questions for Dr. V? Sarah, I see your hand.
Yes, I was just wondering what sort of criteria there'll be so that the pre-authorization goes through.
Yeah, thanks, Sarah. So So the first thing is that the service must be medically necessary, and we define medical necessity in this policy as really addressing health, independence, and safety. As you are likely aware, applied behavior analysis is used in a variety of settings for educational goals. That is not within the scope of this policy, so it has to be medically necessary, again, looking at health, independence, and safety. There are some pretty stringent criteria around making sure that that individual does in fact have autism spectrum disorder. So we require a comprehensive diagnostic evaluation, similar to what is described in the American Academy of Pediatrics policy statement on evaluation and management of children with autism spectrum disorder. This requires an assessment using a standardized, validated, evidence-based tool, such as the ADOS or the ADIR. And while we call those two out, it could be any evidence-based, validated tool that is not simply a screening instrument, and really a tool that gets at assessing symptom severity according to DSM-5 criteria. And those are kind of the big things that I would want to call out when it comes to being eligible. But again, must be under 21, must have a diagnosis of autism spectrum disorder, and must meet those medical necessity criteria.
Oh, thank you. Thank you. And one thing maybe you could take back to your agency is that in my area, I'm in El Paso, there are very, 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 very few people that do any of those standardized instruments that you all are limiting to. So just a thought, because you know, there's probably just a couple, probably only 2 people in town, 3 people in town that do it. So
yeah, that's great feedback, Sarah. And I'll tell you that we worked a lot with our colleagues at TRICARE, who have had quite a few years of experience with providing applied behavior analysis. We also dialogued with lots of other states, other payers, and felt that at the end of the day, to ensure the clinical fidelity of this benefit, making sure that we have the right diagnosis is really important, but are definitely monitoring that specific issue of the prior authorization, working with our managed care organizations to make sure that they are aware of this requirement, and we'll continue to take feedback from folks. But we certainly know that will likely be an issue. And and I know you mentioned in El Paso, you know, where I practice in San Antonio, it's certainly challenging as well. And so definitely top of mind for us. Thanks, Sarah.
Very good. Joe, Dr. Blader?
Ryan, first let me say that we're all very excited to see you in this position and very gratified. Can't think of anyone better to be in this position of both responsibility and innovation. My substantive question concerns what's your take on the current workforce in Texas of people who have that qualification to do either ABA or functional behavioral assessment and the related treatments? And I ask because we do have, at the moment, it's a somewhat limited focus on workforce development, where we started out focusing on child and adolescent psychiatrists. I think we, in the context of ARPA, we broadened it a little bit to helping some LPCs move their trajectory toward practice independence along. And I'm curious if this is going to be a high demand area where we might have to think about some augmentation.
Yeah, so yes, I think that the workforce is certainly a challenge, and we know that it's a challenge in other state Medicaid programs. It's a challenge in the commercial sector. It's a challenge with TRICARE. There's, you know, similar to, I think you mentioned child and adolescent psychiatrists. At least in my time on this planet, I don't think we're ever going to have enough child and adolescent psychiatrists to meet the need. You know, and I can see a similar analogy with BCBAs and licensed behavior analysts. And so, you know, there is certainly a need. We got feedback along the way about allowing other provider types, such as psychologists, to deliver ABA. And again, as we come out of the gate here, looking to the evidence, we started with licensed behavior analysts, but we are aware that there are other provider types that do and can and are able to provide this type of service. And I think, again, we called this an autism services policy because we wanted to take a holistic approach, recognizing that not every child or individual with a diagnosis of autism spectrum disorder is going to benefit from this service. But we want to do all that we can to make sure that it's available. But workforce is certainly a challenge moving forward, and one that is important to Medicaid, and we certainly have a role to play. But that specific issue is bigger than Medicaid, and we're going to rely on groups such as this one to help with that, with the training pipeline and making sure that we have more providers.
Wonderful. And if it's any additional incentive, you're certainly hitting a very important nail on the head in our field, given all the rather justified concern about the proliferation of the use of antipsychotics that's still highly prevalent in the developmental disorders population, even if it's tapered a bit in some others among young people. Thanks a lot, Ryan. Wonderful work.
Very good. Thanks, Joe. Dr. Bapato.
Thank you so much. First of all, I just want to say thank you to Dr. V for the amazing work you're doing. This has been, we've been waiting for this for a long time. So kudos to all your efforts on that. For some of us child psychiatrists who our specialty is autism, and there's usually a long waiting list. I want to talk also about what Dr. Martin said about the prior authorizations. I mean, if we were able to see some of these kiddos in our clinic, and we could give them the diagnosis based on the DSM-5, isn't that just acceptable without the neuropsychological assessments? Because there is a long waiting list there, and there are not so many people that are doing it around the location for my patients.
Yeah, Dr. Bobatrop, that's a great point. I think there will be an opportunity to kind of continually revisit the way that the policy is working, and we are aware that there are wait lists to get some of those assessments completed. And so I think one of the paths forward could be what you describe, where that symptom severity assessment according to DSM-5 might have a bigger role to play. And I failed to mention that we have these requirements around initial diagnosis. There's also a requirement that every 3 years at that interval, a reassessment is done to look at symptom severity, and again, using a standardized diagnostic instrument. I think that the initial evaluation, at least from where I sit, there's definitely a need to make sure that there's a standardized assessment done. However, some of the feedback that we've received from other folks as we've kind of moved forward is, okay, well, let's look at that reassessment requirement. Is there a way where we could allow some other type of diagnostic assessment to meet that requirement? And so we definitely are thinking about that. And I will put my email address in the chat as well. And so these are excellent suggestions, and I would really appreciate it if you would put those in writing and email those to me, and I can share them with our policy team.
All right, very good. Dr. Martin, I see your hand. Is that a second question?
Yes, I have a second one. Thank you. And what about if the ADOS, I know academics is out, but what if there has been an ADOS that has been performed through the school system by a school psychologist? Will that be accepted?
Dr. Martin, the answer is yes.
Yeah, okay.
So,
all right, that's actually really
yeah,
big relief. That really expands everything.
Yeah, the policy allows, it's really an interdisciplinary approach, which is why we unlocked that other code for a team meeting. So it could be done by a school psychologist in partnership with a general pediatrician. It could be done by a developmental behavioral pediatrician on her or his own. But yes, school psychologist would work just fine.
Okay, great. Thank you.
Very good. Dr. Bryant?
Hi, I was wondering, what are the requirements for a licensed behavioral analyst?
So I would point you to the Texas Department of Licensure and Regulation, which is the state agency that licenses licensed behavior analysts. I just can't remember off the top of my head what those specific requirements are. I certainly know what the ones are for physicians,
right.
But TDLR is going to be the place to go for those specific requirements. And then we as Texas Medicaid require them to be licensed. And there's some other things we call it in the policy about registered behavior technicians, licensed behavior analyst, and the assistant kind of level. But TDLR is going to have the better answer.
Great, thank you.
Very good. So Steve Pliska, I saw your hand up a little while ago. You're good? Okay, your hand's down. Okay, and Octavia, your hand is down now. You don't have any follow-up? Okay. Any other questions? So Ryan, I think there's a couple other things you wanted to touch on today with HHSC. Why don't we do that, and then we can kind of think through maybe an organized way to get you some feedback, okay?
Perfect. So a couple other really exciting things that I'll call out, and both of these things that are next in my mind harken back to legislation. So Senate Bill 1177 from the 86th Texas legislative session directed the agency to look at what are called in lieu of services in Medicaid. And in lieu of service is not a new benefit on its own, but is an optional service that a managed care company could provide in lieu of another service, provided that it is both clinically appropriate and cost effective. And so this is a phased implementation for us. Phase 1 includes things that I am sure you are all familiar with, such as partial inpatient, intensive outpatient, crisis stabilization services. And so again, these would be covered as an in lieu of service, where a Medicaid managed care company could provide that in lieu of an inpatient hospitalization, as an example. And there's phase 2 and phase 3. And yes, the 86th Texas legislative session happened a few years ago. We continue to work with our federal partners at the Center for Medicare and Medicaid Services about moving forward with phase 1, and we are eagerly awaiting a final discussion with them to be able to move forward. Some of the other types of services that we're looking at covering through in lieu of are functional family therapy, multisystemic therapy, and I will send you all in follow-up a list of all of those services. But we are working very hard to get this across the finish line. Again, the general pediatrician in me has certainly seen the benefit of having some of my kids with serious emotional disturbance and serious mental illness receiving inpatient, partial inpatient or intensive outpatient and doing really well. And so I'm excited to see this come online as an in lieu of service, but we're not there yet. And then the other thing that I'll call out, which I believe is Senate Bill 672, it directs the agency to implement the collaborative care model as a benefit of Texas Medicaid, which is also really exciting, kind of getting towards truly integrated medical and behavioral health services. And so we've worked with lots of stakeholder groups, specifically Meadows, Mental Health America, to bring that benefit online. And we are looking, I think, at bringing that online later this year. And so again, I have a more specific date and the talking points that I'll send you out, but really looking to that to build out the continuum of care and supporting, the delivery of mental health services in a primary care medical home. And so those are two other things that I wanted to call out. But I'll pause there, Dr. Lakey, and again, happy to take questions.
Yes, Dr. Martinez.
Dr. V, this is Octavio. Are you familiar with the reports of Behavioral Health Integration Committee put forth when it comes to the collaborative integrative care model and recommendations that we made to Texas Medicaid, Medicare?
Yes, I am, just not off the top of my head, but I do believe that was one of the documents that we looked at as we've moved forward with this, but I would appreciate it if you would send me those so I can have it be at the top of my box.
Will do. Thank you.
Yeah, thank you.
Other questions? And was there anything related to maternal mental health benefit that you were going to touch on, Ryan?
Yeah. So as you may know, a few years ago now, this was certainly before I was in this role, Texas Medicaid, at the direction of our legislature, brought on a new benefit, which is a postpartum depression screening that can be billed on the child's well visit for the mom. That is a optional screening that can be done, technically at every well child visit, but Texas Medicaid reimburses once between 0 and 12 months of age, again, allowing the primary care provider to screen the mother and then bill on the infant's well child, or Texas Health Step visit, as we call it. We continue to monitor the utilization of this, and it's not where we want it to be still. We're aware of other barriers, like, okay, so my patient's mother screen positive, what do I do now? Or having the ability to integrate that screening into a practice's electronic health record. How do you document this appropriately to where you're still protecting the mother's privacy? And so we continue to work through some challenges and certainly look to this group for ideas, but that has been in effect for some time now. I know it's been integrated into residency training programs, at least for pediatrics, and that's really exciting. And then I think on this issue, just more broadly of women's health, you may know that the Healthy Texas Women program, which provides benefits to women who qualify after they transition out of Medicaid, we continue to move forward with that and are bringing online a separate but connected program called Healthy Texas Women Plus that will provide coverage for additional medical conditions such as high blood pressure, diabetes. So not directly related to mental health, but certainly important at kind of expanding the continuum of care for women in Texas. And then we're very interested in the new work of the consortium when it comes to maternal health around perinatal health. And I know I've shared with Dr. Lakey and Luann that we look forward to partnering and helping to level up those activities as y'all move forward.
Very good. So Ryan, it sounds like, well, first, are there any other questions for Ryan? So Ryan, it sounds like that we need to exchange some documents with each other, maybe. And Octavio, the documents that you brought up, we'll get that to Ryan. Ryan, it sounded like there were some speaking points that you have or could be shared, and we'll send that out to the group. But the one that sounded like you needed feedback on maybe quicker than others was the discussion on autism. And so I'm wondering if it would be helpful to you if we can share that with the executive committee here and ask the executive committee to think through that and put their thoughts together. And instead of sending them kind of haphazardly to you, if our executive committee members would send that to Luann here, and we'll try to put that together and have a formal response to you related to maybe some feedback and opportunities to enhance that autism benefit here in Texas. Would that be reasonable, Ryan? Would that be helpful to you?
Yeah, it would. And, in terms of timing of that, I think now is fine, but the benefit has only been available for just barely a month. And so, and of course, I recognize, believe me when I say that we know that there's been some pent up demand, but I'm also keeping my ear to the ground and talking to pediatrician colleagues and family doc colleagues specifically around the prior authorization issue to see what impact that is having. And so, again, I think feedback now is good, but there might be more feedback to provide in another month or 2 months, again, as the benefit continues to roll out. I'll tell you that the managed care organizations have already begun to receive prior authorization requests. Children have already started to receive services, so that is good. But I think we will continue to learn about issues as the benefit continues to expand. But the process that you described, Dr. Lakey, that sounds great.
Okay, very good. Ms. Wesley?
And Ryan, did I hear that you were also going to share information on the collaborative care codes that will likely hit the ground this year, and how we can plan and anticipate and prepare for those?
Yep. And I believe the codes were already presented at a rate hearing last year. I will make sure to attach that rate packet, but the talking points that I have prepared, I think, cover that too.
All right. So Ryan, any of that material that you'd like us to share, just put it together and we'll get it out to the executive committee. Again, would ask the executive committee to go through that. And again, specifically to the autism, if there's some insight that might be useful, we'll put that together. And then later on, Ryan, if we need to do that again, we can put kind of on a ongoing basis, giving you feedback from the mental health community, the psychiatrists, academic psychiatrists some opportunities to enhance the rollout of that benefit. Sound good?
And for my materials, who would you like me to send those to?
Why don't you send it to Luann?
Okay. Okay.
All right.
Yep, Dr. V, the other thing that I wanted to mention is the in lieu of services is extremely important to all of us on this call. Because we know how important MST, FFT, partial hospitalization, et cetera, all of the above are to the children and youth that we're providing services for out in the community. So any other additional information you can provide along those lines would be extremely helpful as well.
Yeah, Luann, I'm right there with you. We continue to work with our federal partners to move forward with this, and again, hope to be in a position to be able to do so very shortly.
All right, very good. Any other comments or questions? If not, Ryan, you're welcome to hang out with us if you want to, or if you have other work that you need to do, feel free to drop off and take care of it. But thank you for being with us today, and we will invite you back.
All right, thanks y'all very much. I'll put my information in the chat in case you want to connect offline. I'm here to help. Thank you everybody so much.
Very good, thank you. All right, so Steve Pliska, we're gonna jump back to you. We were going through the cost updates and went through item A, and I think also talked about part C and D, but on the CP, we thought it'd be good to have just a brief update on how things are going and maybe some whatever you want to talk about related to CPWE right now.
Okay. Well, I'll be fairly brief since I hadn't prepared anything specific. I think one of the, what we're trying to do right now with the CPWE Operations Committee is to kind of get everybody on board and comfortable with the reporting metrics. And while they on the surface appear relatively simple, they in fact require a fair amount of logistics to kind of pull these things together. So we have on the clinical level of activity, number of unique patients, a number of visits, we have two major sources. One for those CPWE programs that are affiliated with an LMHA, we're pulling that from the central HHSC reporting, and Dr. Rishi Swani has been very helpful in that regard. But we're refining those numbers and make sure everybody understands them, looks at them, be sure that they reflect what's happening with their particular residents. Now, multiple programs have affiliations with non-LMHA programs. We are incumbent upon those programs to submit manually data on their activity level via spreadsheets to the internal evaluation team. Now, the other so that's a bit tricky, and it was clear in the last meeting that there continued to be when the data management committee started looking at the data, it was clear there were some misunderstandings amongst the HRIs on that data. So we have to kind of go back and relook at that. But it's more or less a matter of collating accurately the data that we know is out there. Another big aspect of the metric is surveying the residents who participate in the CPWE programs. Each of the programs are required to submit to the internal evaluation team the list of their residents that are rotating, the dates they rotated, and their contact emails, so that the internal evaluation team can send the necessary surveys. And again, the internal evaluation team is working with the individual HRIs to get that going. The long term, probably, which will be at the end of this year, we'll be looking at a metric in terms of graduating residents, what the impact of polling them about their views as far as whether this would make them more or less likely, to enter a career in community psychiatry. I suppose one thing that both Laurel and the internal evaluation team and I have noted is that there seemed to be more on the logistical side as far as collecting this data than we had perhaps anticipated. These metrics all appeared very simple at first blush. You just punch a button and send it in. It's turning out to be more complicated than that. And there could be some administrative time that ultimately will need to be put toward these tasks if we want to really get this data, get it accurately. And there's probably a little bit of an administrative burden on the HRIs that perhaps was not anticipated at first. The next CPWE Operations Committee is this month, I believe. Laurel, do you have that date? It's this week, in fact? Or is it? Yes, it is. It's this Thursday.
Is this Thursday?
And then I'll get it. We're meeting every other month. I'll get an update from how things are going on a clinical side. There are a number of new programs that are getting underway. I don't know if any of those folks would want to, people who started a program in the last 3 to 6 months, if you'd like to say a few things on how it's going or where it is, that might be helpful for the committee.
All right.
Oh, maybe they're not here. They don't want to say.
Okay.
Hey, Carol, you guys have launched, haven't you? Or are you still working? And are you with MetroCare or did you go with somebody else?
Steve, we went partially with MetroCare. We went partially with Parkland. And then we've set up a couple of CPWE opportunities in rural areas in some counties north of Dallas.
Good. Okay. And Dell, I believe you started recently, correct? Dell Medical School?
Yes, indeed.
Yeah. Charlie, do you have any update on where things are?
Really, Roshni's in charge of this, but we're working with 2 local mental health centers. One is Integral Care and the other is Blue Bonnet.
Okay.
So things are progressing nicely.
All right, very good. That's all I have to report at this point. I believe, David, did you say you wanted to have more of a focus on CPWE at the March executive meeting?
Yeah, and so maybe let me touch on that now. And actually, I think it's going to be an April meeting. Looking at a variety of things, I think we're going to need to push the March meeting out to April. But I think Danette Castle brought up a really important thing last time related to sharing best practices related to how we're working with the local mental health authorities. And I would like to propose that we have a significant section there in that meeting to highlight the work that's going on, but also share the challenges and how institutions have worked through those challenges to put these programs in place, because it does seem to have a significant opportunity to do a lot of good things. And I know some institutions have had challenges putting it in place. So let's spend time next meeting sharing what those best practices are and how. And Danette, I would like you to be part of that conversation. And if you want to invite some of your colleagues from the local mental health authorities to share kind of their perspective in what's going well and what some of those opportunities for improvement would be, I think that would be great.
Yeah, I'd be happy to do that. And I am really pleased with some conversations taking place with a new site with Baylor Scott and White and the local mental health authority in the Temple area too. I see Dr. Burgess on here, and I know you guys have a conversation coming up. They're really excited about it. But yes, I think it would be a great opportunity. I hear in the main a lot of positive feedback. I know there are challenges, there always are when various organizations work together on a new initiative, but I know there are some really good outcomes happening around the access side, really good experiences with the various residents that are involved. So look forward to that.
That'd be great.
Danette, will you be at this Thursday's meeting? Do you have that on your calendar? I see you
I
did
do have it on my calendar.
Excellent. Okay. Well, then we'll have as an agenda item beginning to think about what we need to do for the April meeting.
Yes, there's at Baylor Scott and White, what we're hoping to do is do 2 convergent things. One is use CPWE to expand the residency cohort, and 2 is then use that to have the resident staff a similarly planned county mental health crisis unit, which has never existed before. So we're trying to bring those 2 things together.
And
that sounds exciting.
Actually, James, are you on the, have you received an invite to the CPWE Operations Committee yet? Probably not, since you haven't started.
No,
Would be
no,
this-
could you add me to that?
Yes,
though?
actually, Laurel, this comes from you. Could you add Dr. Bourgeois to that meeting?
Appreciate that.
Okay. I think another item we ought to have probably on that meeting in April, besides CPWE, is also an update related to the fellowships that far out. The dollars that the legislature put in, are those positions being filled? What's the total number of child and adolescent fellows that will be coming to do their fellowship here in Texas, and how that's playing out? So why don't we go ahead and add that to the agenda? Any other items that people would like to either talk about today that are on the agenda, or things that they'd like us to add for the agenda for our next meeting? All right, I'm not seeing any hands being raised. So I think we're going to be able to give you about 45 minutes back. Again, appreciate all the work that's taking place. I thought this was a good meeting. Again, a lot of good feedback from evaluation, internal, external, the updates on the ARPA fund initiatives, the updates on research. Again, a lot of people working really hard to, again, be good stewards of these unique resources we're trying to be good stewards of. So thank you for the work that you're doing, and we'll look forward to working with you. We'll be sending you some information, as we talked about, from Dr. Van Ramhorst. And if you could look at that and provide us some feedback, that'd be great. Otherwise, I'll see you in April. Thank you.
Bye, David.
Bye.
Thank you.
Thanks a lot, everybody.